Good morning and welcome to the Prostate Cancer Pathways event for patients and caregivers. My name is Chuck Strand. I'm CEO of US2 International, and on behalf of the US2 Board of Directors and staff, I'd like to welcome everybody to the event today and thank you for joining us. In addition to the crowd we have here in person, we also are doing this event as a live webcast. So we have hundreds of people that have registered to watch the live video and have the live audio. And to those folks, thank you all for joining in addition to the folks here. And if you have questions or comments throughout the presentation, we invite you to scroll down to the bottom of the screen that you're looking at, and below the sponsors, there's a field where you can put in your question, your comment, and we'll get to those, as many of those as we can throughout the day. So we'd like to also thank our sponsors, and the presenting sponsor, Blue Diamond, is Janssen Oncology, and additional sponsorship support is from Bayer, Sanofi Genzyme, Astellas Pfizer, Amgen, Genomic Health, Augmenix, AbbVie, and we'd also like to thank our host, North Shore Healthcare Systems. I certainly couldn't do without all of these folks, so we sure appreciate it. The presentation agenda, we've kind of done a snapshot of that here, and really what it's all about is helping for making informed decisions, because we recently heard from a physician who presented at one of our events that, in his opinion, prostate cancer is the most difficult cancer to manage, not necessarily to treat, but unlike some cancers where there's more of a well-worn path between a diagnosis and one or two best-case situations for treatment, with prostate cancer, that's just not the case. There's a lot that everyone has to know in order to have the information necessary to really make good choices for treatment and for management of side effects. So this agenda is meant to provide somewhat of a wider net on prostate cancer overall, but we really do want to dig into some of the specifics too. So in addition to men's health risks and basics on prostate cancer, including PSA testing, diagnosis, the option of active surveillance, in addition to the treatment options, we're going to be providing some information specific to the side effects that include ED, and that leading into a discussion on sex after prostate cancer. And then after lunch, we're going to have a special presentation on urinary incontinence and pelvic floor strengthening, in addition to wrapping up with a presentation on non-metastatic castration-resistant prostate cancer. After this event, we're having another event that's specific to the support group leaders, so we'll have a separate webcast for that. And part of what we're doing here is providing content that the support group leaders can use for their meetings throughout the year and across the country. US2 is a prostate cancer nonprofit that focuses on providing educational resources, support services, and personal connections to the prostate cancer community. And we have more than, in addition to some of the leaders who are here, we have more than 200 support groups throughout the country. And many of these are volunteer-led, so we really appreciate all the work that everybody is doing around the country, in addition to a shout out of thanks to some of the folks who are here with us today, who are support group leaders. Here in Chicago, we have Jim Schrate, who is leader of a support group, in addition to being the vice chairman of the board for US2. And we have Cliff Wall, who runs a support group, leads a group here in Chicago, in addition with assistance from Harvey Orloff. And Norm Thorson from Wisconsin, Lee Hillstrom from Wisconsin, Donna Hollister from Michigan, and Flora Ucoli from Tennessee. So thank you all to the leaders, and also a special thank you to our chairman of the board, Peter Friend, who's with us here today too. So thanks to everybody. In addition to the support groups, we have recognizing that not everybody can make it to an in-person peer-to-peer support group in their area due to geographic limitations or even physical limitations. We reach out to provide support services on different platforms. So we have the Inspire online community, which is a series of blog posts, and it's all categorized by 16 different topics within prostate cancer. So people can log on and ask a question or answer somebody else's question, provide some feedback and perspective. We have a toll-free line that comes into our office in Chicago here. And in addition to answering basic questions on prostate cancer, we also have a second level of volunteers that are a response team. So if somebody calls with a question specific to a treatment or management of side effects, we have volunteers that are categorized by those topics, and we can connect the caller to the volunteer to either speak to them on the phone or exchange emails. Every month we have the newsletter, the Hot Sheet, and some of you may have seen that, most likely most of you. A lot of times the support groups use the Hot Sheet as the agenda for the meetings every month, and it's a compilation of published articles in addition to some columns that include physician content from Dr. Moyet and Dr. Chodak. We recently added another column called Between the Sheets, which is specific to sexual health and intimacy. So we have folks that ask questions, and we answer those in the Hot Sheet. Thanks to Dr. Jeff Albaugh, who's going to be a presenter today. He also is part of that initiative with volunteering his time to respond to questions on the Between the Sheets, in addition to Dr. Ann Katz, who is a presenter at one of our other Pathways events. About 2 weeks after the Hot Sheet, we have another distribution of information that's a compilation of news articles about prostate cancer. It's called News You Can Use, and that goes out in addition to an email that provides an overview of different information that's going on in the prostate cancer community. On our website, which is fairly comprehensive, we also have a clinical trials finder tool, and that provides kind of a shortcut to clinicaltrials.gov. So the clinical trials finder includes all of the trials that are on clinicaltrials.gov, but if anyone's been on that website, it can be a little cumbersome. So this trial finder expedites the process by allowing people to enter in some of their health information and some preferences on what type of clinical trial they're most interested in, and then it spits out a short list of clinical trials that would be of interest to the person. So if you haven't been on that, and if you're interested in trials, we encourage everyone to check that out. And then, of course, educational content from events such as this, in addition to content that's digital and in print. This Pathways event today is the 3rd event in a 3-event series for this year. And in addition to the prostate cancer information that we kind of did an overview of, we did a survey recently to support group leaders to find out what information is of most interest that might need some additional content, what might be underserved in terms of education. And we heard back from the leaders, and we focused the special sessions in each of these 3 Pathways meetings to address those. So in Seattle, our first event, we talked about the genomic testing and the psychosocial aspect of managing prostate cancer, which includes anxiety and depression. And in New Jersey, another of the topics that the support groups wanted to hear more about was sexual health and intimacy. So we did that with Dr. Ann Katz, and we have books up here from her, in addition to books from Dr. Jeffrey Albaugh, who will be speaking today on incontinence and, on ED and sex after prostate cancer. We'll also have a presentation on incontinence from Dr. Heather Moki. So those topics were what we received as far as input and acted on those in terms of incorporating that information into the various Pathways events throughout the year. The essence of US2 is US2 helps men with prostate cancer learn to fight this disease. And the power of US2 is in helping men and those who love them by transforming resignation into determination and fear into hope. And that hope is really grounded in information, solid information that comes from the trials, the research, and the information that we're all working together to share. We're very fortunate to have some expert presenters today, and we'd like to thank all of them, Dr. Helfand, Dr. Albaugh, Dr. Moki Cordova, and Dr. Lowentritt. So we'll be providing an introduction to each of these presenters throughout the day. The first topic we wanted to dive into is men's health risks, PSA testing, active surveillance, and treatment options and side effects with Dr. Brian Helfand. And Dr. Helfand is chief of the Division of Urology and Ronald Elches Family and Richard Melman Family Endowed Chair at North Shore University Health System. He's a director of Personalized Prostate Program and director of clinical research in the Program for Personalized Cancer Care. He's also an active surgical scientist who's involved in the care of patients with prostate cancer. His clinical care and research is focused on the implementation of genetic tests and biomarker studies for prostate cancer. So please join me in welcoming Dr. Helfand. Good to see you, fans. Thank you.
Thank you so much. Can you all hear me okay? All right. I apologize because my voice may be a little raspy. I'm overcoming a little bit of a cold, but I will do my best. And if I fall over in the middle of this talk, just let me know and someone come and revive me. Nonetheless, I'm a urologist. I'm a surgeon scientist. I am focused on prostate cancer. As I always tell people, there's nothing more that I would rather do than talk about prostate cancer at any time of the day. It's just something that I have a strong passion for. And half it is because I love the disease process. I love treating the issues that men face with the disease. We as men are very different than women in so many ways in the healthcare system. This is the start of Men's Health Awareness Month, and it's really recognizing that there are a lot of differences between men and women as we enter the healthcare in our system, and certainly that does include prostate cancer. And our needs are very much different than women's needs. And it's how do we address those needs to make them well known to everyone, and so we can address them the best way possible. So really, when we look at men and health in our country, in the U.S., we got an increasing problem. And that is well established that America, but not only the world, we have our political issues, but we have our health issues as well. We're becoming increasingly obese. Because of work demands, other demands, we're more sedentary. And this body shape is becoming increasingly prevalent. And that poses a major healthcare problem. And so what I want to kind of point out here, again, are why are current barriers to why do men in particular not seek healthcare as frequently or to the same degree as women. And so socialization plays a major part in a lot of men's health decisions to visit doctors. We're kind of brought up very tough. I feel fine. I could push past this, live through it. I don't feel sick. Why do I need to go to the doctor? Big boys don't cry. If it isn't broke, don't fix it. And this prevents a lot of men from appropriately seeking care and even knowing that they should be getting screened for things that they don't have symptoms for. I hear all the time, and personally speaking, it's hard for me to get to to see a doctor because I have a lot of work obligations. I got to take off time someone has to cover. A lot of men, an increasing number of men, have a lack of health insurance. And if I keep putting it off, what I always say, put my head in the sand, maybe I can keep putting it off until I recognize that there's a problem. And so really when it all comes down to all this is that men, unlike a lot of women, don't make their health a top priority. And that's something that we really want to emphasize throughout this. I mean, everyone in this room is motivated, which is great. But when we look globally, and certainly in this country, a lot of men do not make health care, and certainly prostate cancer screening, their top priority. So these are some of the basics, just to review, of what we should be doing before we get on to talking about prostate cancer. But every man, and there's some debate as to when this should actually start, but certainly age 40, potentially age 50, should be getting an annual health exam. You should visit an annual health provider every single year. Just like prostate cancer, where I always tell people, know your numbers. Know your numbers not only for prostate cancer PSA, but know your numbers for your blood pressure. Do you have high blood pressure? Are you hypertensive? Know your cholesterol numbers. Is that being addressed? Knowing, are you diabetic? What is your fasting glucose level? Do you have blood in the urine? What is your PSA? Make prevention a priority. Be proactive about your health. Don't let someone tell you, you tell the doctor, this is what I want. Understand as much as possible, because that is going to help drive the process. Physicians are very busy. It's very easy to get lost in the system. Know what you need to know. You don't need to know everything, but but ask these questions because it's going to make your screening more proactive to make sure that you're getting screened appropriately. Detect problems early. Screen for the common cancers, colon, prostate, other cancers. And if you don't understand, ask questions. It's your body, so you should know what's going on. Don't just kind of chalk it up and say, I think this is part of aging. I go to the bathroom all the time. That's just a rite of passage. No, ask questions. Is this normal? What should be happening? Again, a lot of this is kind of common sense, but when you think about it and you go to the physician, most guys in particular don't ask those questions. And that is why when you look at the leading causes of death in the United States, the #1 killer right now continues to be heart disease. A lot of that can be prevented by taking active roles, exercise, diet, etc. We still have a large cancer problem in this country. It is decreasing overall, but certainly the number of men and women, for that matter, dying of cancer is significantly prevalent. Chronic respiratory disease, accidents, stroke are all still major killers in this country. So how can we just briefly, and that's not the purpose of this lecture, but just when you go to the physician, make sure that you are getting what you need to get done. Make sure when you're going to the doctor that they are addressing cardiovascular disease. This is something that honestly most physicians, internal medicine doctors, family medicine practitioners do a great job of, is are you getting screened appropriately for cardiovascular disease? There's a lot of incentives for the physicians to make sure that you have a low blood or a normal blood pressure. You're not hypertensive. They're checking for coronary artery disease and they're looking for risk factors for stroke. To prevent cardiovascular disease, again, we go back to make sure that you're getting at least an annual physical. Lose weight, choose a healthier lifestyle, get into a regular exercise routine. This is very difficult for most men to do because, hey, I get busy with work. But if you make it a priority, you get up at a certain time each day and you work out or do it at the end of the day, even if it's 15 minutes, it makes a difference. Get active, stay active. It helps your body, it helps your mind. Do that. Do things to reduce stress. That's one of the hardest things that we have in this country. How do we get rid of stress? But that's through exercise, doing enjoyable activities. These kind of things all help the risk of cardiovascular disease. Stop smoking. That's one of the easiest things on paper to do, one of the more difficult things to do in life. While the risk of smoking and prostate cancer is not the most well established, certainly smoking contributes to many other cancers, lung cancer, kidney cancer, bladder cancer, etc., that we can prevent by just stopping to smoke. So things to look out for there. Diabetes, you should be paying attention to your sugars. We know that uncontrolled sugars not only contribute to many cardiovascular diseases, high blood pressure, stroke, etc., but certainly in the cancer realm, having uncontrolled sugar seems to be a bad thing. Pretend worse disease, more aggressive disease, get that under control. The more we control that, the better that we can keep you healthier. So make sure that they're checking for fasting sugar levels. Lose weight again, more exercise, control your blood pressure, and eat a balanced diet. These days, and diet recommendations change throughout time. However, we know that the healthy diet, at least in vogue right now, seems to be a low carbohydrate diet, all the stuff that tastes really good. We don't want to eat tons of. We want to have a balance, okay? And that's one of the things that we emphasize here is that if we can do something to promote a healthier lifestyle, not only through exercise, but a healthy diet, rich in fruits and vegetables, low in the stuff that all tastes good, that's going to help control your diabetes and your risk of other common diseases. In terms of cancer, what can we do? We need to recognize risk factors for cancer. This includes obviously prostate cancer, but certainly colon cancer, pancreatic cancer, et cetera as well. And so what are the risk factors? We know that race, we can't do anything about, but know that if you're African American, that you are higher risk for many of the other cancers. We can't change that, but certainly recognize the fact that earlier screening may be beneficial. Family history. This is one of my big points that I always make. We as men are terrible at knowing what affects our family. Women are a little better, but certainly there are so many limitations to family history. We don't know why Uncle Bob died. He died of old age. He didn't die of old age. Figure out why he passed away and figure out if he had cancer, because if they had cancer, that imparts increased risk to you. Know your family history. Be prepared to talk about it. Know if there's any breast cancer, colon cancer, ovarian cancer, pancreatic cancer in the family. Write that down, not only so you should know it, but also any family member should know it as well, because it's useful. Again, tobacco use, if you've ever had a history of it, know it, share it with us. Certainly, we're going to try to curb that behavior because it does increase that risk of other cancers. If you've had any other cancers, we need to know that because that's going to potentially increase your risk of developing a secondary type of cancer. We want to know about cancers because in this room we, I think, can all appreciate that early detection of cancer gives us the most options so we can treat it at a time that's very favorable. So we want to get screened. Again, ways we can reduce our risk here is don't smoke, eat a healthy diet, stay active, exercise, and of course, for skin cancer, wear sun's protection. So in this country, we have to look at what are the major cancers here, and as we talked about here, lung cancer is the biggest killer, but followed by prostate, colon, pancreas, etc. And so how can we screen for these various cancers? And then obviously I'll start focusing on prostate. For lung cancer screening, we don't really regularly offer lung cancer screening to everyone. But we do offer it if you are considered to be high risk, meaning that your age is between 55 to 74, you currently smoke or have quit smoking in the past 15 years, and you have at least a 30-pack year smoking history. And if you are considered high risk, based on that, we will do an annual lung screening with a low-dose CAT scan at increased risk. Sometimes physicians will get an X-ray if they suspect it and you don't meet that criteria. But it is something, again, for lung cancer in particular, that the biggest thing that we can do to curb that risk is to stop smoking. But if you have smoked in the past, we want to make sure that you're getting screened appropriately. What about for colon cancer? So this year, the colon cancer recommendation for screening has changed. Instead of getting a baseline screening starting at age 50, we're now getting that at age 45. And that's just due to the prevalence of young men who were diagnosed with colon cancer and even aggressive colon cancer at early ages. And based on this and epidemiologic data, the American Cancer Society now recommends screening starting age 45, an important thing to notice and to discuss with your physician whether or not you should have that kind of screening starting at that earlier time. The way that most commonly we do screening is by having men drink that, and women for that matter, drink that gallon of delicious tasting stuff that cleans you out. You don't leave the bathroom for a day, but then we perform that colonoscopy. And actually, you should continue this kind of regular screening until age 75. Now, depending on what the gastroenterologists find during that colonoscopy, they're going to tell you the frequency of that screening. If they find polyps and they find certain characteristics to the polyps, they're going to recommend more frequent screening. If you have a genetic predisposition to colon cancer, they're going to recommend anywhere between annual to every other year screening. So that is something to talk about not only with your physician, but also with the gastroenterologist as well. But you should undergo screening. It's something as a urologist, I always ask my patients as well, are you undergoing routine colonoscopies? Make sure to get checked. It is a common cancer. It's something that we can intervene on that makes a big difference. If you're over 75 years old, discuss this with your physician. Certainly in this community, we have longevity. And so, I think for many of our patients, colonoscopies after the age of 75 are very reasonable. But it is a risk balance. If you're sick and have a lot of medical problems, you may not want to get a colonoscopy. But again, in our community, men and women tend to be extremely healthy, living into their 90s, et cetera. So you would benefit from continued colonoscopy and colon cancer screening. So now, getting back to my passion here, prostate cancer, and why half of us are in this room, how can we get screened and know about prostate cancer? So I want to, again, just to make sure that everyone in this room is on the same page, I want to start really from the very basics of what a prostate is. So again, this is really giving the basis for our knowledge here. But anatomy, because I think we forget, and certainly when I speak to most men, even after the diagnosis of prostate cancer, they still don't know what the prostate does or where it is. It's called the prostate, not the prostrate. It lives at the base of our bladder here. So if this is our bladder, and here is the prostate right at the bottom of it, the tube that we pee out of, called the urethra, goes through this and ultimately empties out through the penis. The normal purpose or the normal function of the prostate is to make fluid for ejaculation. It is very important for reproduction. It is very important for having some type of urinary control. On the other hand, after reproductive years, I always say it does nothing good. It either enlarges and causes urinary symptoms, or it gets cancer. So it is necessary for reproduction, but it is not necessary for life. And so what happens, as I said, in the prostate, as we age, the prostate tends to enlarge. In fact, by the age of 80 to 90% of men will have some degree of urinary symptoms. I get up in the middle of the night. I go to the bathroom frequently. That is the concept of I'm aging. This is a normal part of aging. Yes, that is true. But if it is bothersome, we can do things about it. The other thing that tends to happen, and this tends to happen more in younger men, but is inflammation of the prostate, what we call prostatitis. This can happen on a very acute basis, meaning that all of a sudden in the last few days I feel like there's some pressure down there, I feel some pain, or it can kind of happen chronically to some degree. Again, this is generally because of inflammation, but it can get an infection too, what we call a bacterial prostatitis. This is not prostate cancer. We generally don't screen for a prostatitis, and that's something that is symptomatic, but we do screen for urinary symptoms. I'm going to the bathroom. So that is something to bring up to your primary care to talk about. Hey, I'm going to the bathroom more frequently. Is there anything that we can do about it? So again, to focus on what is benign prostatic hyperplasia or benign growth of the prostate, this is really growth of the central portion of your prostate. Again, I always describe the prostate as an orange that sits there. Most cancers like to form, about 80 to 90% of them will form in the peel of the prostate. But the juicy part, the inside part, is the part that in every man will start growing to some degree that compresses the tube that you pee out of. And that is associated, at least classically, with the increased risk of having urinary symptoms. So urinary symptoms that men experience as they get older in the era of PSA screening are largely due to just that central growth of the prostate. And the urinary symptoms themselves are generally not due to prostate cancer, unless it's an advanced prostate cancer. So just because he's experiencing urinary symptoms, again, does not mean that he needs to get checked for prostate cancer. It doesn't mean that you have an aggressive prostate cancer just because you have urinary symptoms. In my clinic in particular, I always say that once a man is diagnosed with prostate cancer, it is not uncommon for him to come and say, hey, I'm going to the bathroom more frequently. This is a prostate cancer getting out of control. It's generally not. It's our anxiety over the prostate cancer that's causing those urinary symptoms, but it's generally, again, in the era of PSA screening, not because of the cancer that's causing those symptoms. And about 1/3 of men living, as I said, until age 80 will require treatment because of urinary symptoms, not because of the prostate cancer. And again, just to visualize this, if this is the normal prostate, here's the bladder, here's the tube you pee out of. As we age, this central part of the prostate grows, the inner juicy part, and it compresses the tube that we pee out of, making it harder for the bladder to empty appropriately. So prostate cancer is a major health problem in this country. And so again, it is the most common non-skin cancer type of cancer that we have, about 29% incidence. However, if you look at the rate or the frequency by which men die of prostate cancer, there's a huge discrepancy between the number of prostate cancers we diagnose and the number of men who ultimately go on to die of the disease. So in this country, just to go through, a man is diagnosed with prostate cancer every 2.4 minutes. A man dies of prostate cancer every 20 minutes. The overall lifetime risk of developing prostate cancer depends on the era that we look, but it's generally about considered to be 1 in 7 men, or about 14%, versus the risk of dying of prostate cancer is about 1 in 34, or 3%. And this incidence and mortality is twice as high in African American men. That's why we pay attention to race as a risk factor. And this is not necessarily because of a disparity in healthcare access. It actually has to do a lot with biology as well. So what are the causes of prostate cancer? We don't really know most of the time. It is a very heritable genetic disease, which is a subject of my research interest. But the risk factors that we can pay attention to, again, our race, African American, are higher risk. Heredity, meaning that if you have family members with prostate cancer, first degree, your father, your brother, an earlier age of diagnosis, that's going to impart increased risk. We do have now genetic tests that we can utilize to help better estimate those risks. That's a whole nother lecture there, but these are ways that we can now appreciate why men get prostate cancer. Certainly, if you have a family history of breast cancer, if you have a family history of ovarian cancer, other cancers, that's going to impart increased risk for prostate cancer. We should be aware of that. That's why it's so important to gather that family history information. Diet may play a role. We don't really know all of the diet risks, but it certainly does. And those men who are more sedentary seem to have more aggressive type prostate cancer. So that's why we emphasize being more active is a way to potentially reduce your risk of prostate cancer. So again, what is the ideal? This is the same thing I would tell someone for heart disease. Maintain a normal body weight. That's going to be good not only for prostate cancer, but every other type of disease. Consume low fat. Try to increase your servings of fruits and vegetables. Reduce your consumption of red meats, especially charred meats. It has been suggested on many occasions that barbecued meat, charred meat may give you those additional toxins, which may be associated with prostate cancer. Exercise for at least 30 minutes. Again, these are a lot of just general health good things to do, but they do all seem to fall out of analyses that may help prevent prostate cancer. So what is the screening for prostate cancer? The screening for prostate cancer really involves two things. And unfortunately, we can't get rid of the first one, which is the digital rectal exam, which most men would love to get rid of. But it does always fall out of every single study that we have that it is still a significant predictor of not only prostate cancer, but often aggressive prostate cancer if you had an abnormal digital exam, meaning that we felt a little rock on your prostate. Most importantly, in this country, we use the PSA blood test, which has been controversial over time, but it does promote early detection of prostate cancer. When used correctly, it does help us identify prostate cancer at early time points. Again, here's just the digital rectal exam, which every man loves. No one ever feels bad for the urologist who has to do that many, many times a day. But it's equally painful for all of us, but it is a necessary part of the procedure. So what is PSA? PSA is a protein that is made exclusively in the prostate. And its normal function is to liquefy semen for after ejaculation. This is the part that contributes to the reproductive health that we have. But that's what the PSA function is just to make it so that it's a little bit more liquidy when in our ejaculate. But PSA is not just specific for prostate cancer. That's what makes it controversial in many ways. It can be elevated for many other reasons. I always say that if you have a big prostate, inflammation, infection, sexual activity, exercise, if you look at PSA the wrong way, I'm convinced that it can go up. But trends over time are important. And I always say that, and this is certainly what most primary care physicians use, they're looking for a value less than 4. Okay, that's the simplest, easy way for them to look at it. But really, what's more appropriate is to look based on your age. And if you would believe it, a normal PSA for men in their 40s is really less than 0.7. In your 50s, it's less than 0.9. In your 60s, most men should be under 1.3. And in your 70s, most men should be under 2.2. And if you look at, if you've ever had prostate cancer, when your PSA probably went above that, that's probably the start of when things started to go awry, meaning that you either could have had the initiation of prostate cancer. Again, prostate cancer is a very slow-growing tumor. But again, most men really, on a population level, have PSA values at these very low levels. So while we often use 4, you're usually an overachiever way before you get to 4.
What's NGML? What is that?
That's just the concentration. So it's in nanograms per mil. That's just in the concentration we measure at. So PSA blood test has gotten a lot of bad publicity. And as a urologist and someone who's prostate cancer, I'm the one who tries to fight against that, because I do think that there's a lot of good to it. But certainly, based on all the controversies, these days there's a lot of alternatives. So what is the good of prostate cancer? PSA was really first described by my mentor, Dr. Bill Catalona, back in 1991. And it really was the first demonstration that PSA could be used as a screening tool for prostate cancer. And really, since its introduction, the number of prostate cancer cases that we've diagnosed has risen. And that's what a test should do, is that we're able to identify more cases. And if you look at this, and this is kind of cut off here, but that since its introduction in 1991, the number of men that have died from prostate cancer has decreased over 45%. So if you look just simply at that on an epidemiologic level, PSA has been a success. That's good. In fact, there was an 80% decrease in the percentage of patients with metastatic disease. That's also, in my opinion, a great test that can do that. And again, that's at 45% of men dying from prostate cancer. So the test did what it was supposed to do. But it was criticized. And the reason why it was criticized is it may be harmful because not all prostate cancers are aggressive. It's when we hear that C word, the cancer word, that everyone says it's going to spread throughout my body very rapidly. And the truth is that not all prostate tumors have the same potential to spread outside our prostate. And so PSA doesn't discriminate between the non-aggressive type of cancers. And based on this, you have to screen about 200 men and treat between 5 to 9 men to prevent one death. And PSA, again, isn't perfect. And so there are men who have really aggressive prostate tumors that produce very little PSA, and PSA actually fails those patients because it doesn't pick them up. And 30% of men with prostate cancer and a PSA greater than 4 already have disease beyond the prostate and may be incurable, so it may have been too late. Again, this is why PSA has been criticized, but I think that if you weigh the good part about it, the fact that it's decreased mortality, decreased metastasis significantly, it's still a good test. So I think the PSA benefits outweigh the harms. We need to balance it based on your overall health. Men who have more than a 10-year life expectancy should get screened, but what we really recommend is a shared decision-making with your physician. Now, for shared decision-making to work, you have to take a proactive role. You have to go to your physician. You have to bring this up and have that conversation. That doesn't happen very often. A lot of times they just order it. So it is something to make sure you understand what this is before you're going into it. Ask your doctor about this. So what are the alternatives? If you look at just a single PSA value, so maybe you're not going to get screened with PSA every year, but if you get screened before the age of 50 and you have a PSA that's over 1, you have a significantly elevated risk of being diagnosed with prostate cancer throughout your lifetime. That single PSA is actually very prognostic. So I encourage everyone, even though guidelines don't necessarily tell you, get a single PSA level and then decide how frequently you would want to get screened. But there are so many other, and this is just a small list of the new biomarkers that are out there. This slide itself, I can't believe I'm sitting up here just talking and limited to one slide. I can talk about any of these tests to nth degree. Many of them perform a lot better than PSA. So if you use a PSA as an initial screening tool and then obtain one of these other tests, it can help better define your risk of needing a biopsy, of having aggressive cancers, etc. So again, talk to your primary care doctor about this, but also bring these up to your urologist saying, hey, I know my PSA is high. I don't need to rush into a biopsy. Are there other tests that we can use to decide if I need to work this up further? One of these is called the Prostate Health Index, or PHI is the other name for it. And this is really a test, as an example, that measures different isoforms of PSA. So you have the native isoform PSA. It is initially produced as a large molecule that's subsequently cleaved, so chopped up into PSA, and then a molecule called 2-Pro-PSA. And that 2-Pro-PSA is a lot more specific for cancers, but also aggressive prostate cancers. So that's what this test kind of uses. And if you look at it and you obtain a prostate health index score before you do a biopsy, it'll tell you the risk of cancer if you did that biopsy. And so if you have a high score, it's going to say that you have about a 1 in 2 chance of getting that biopsy, so you should undergo that biopsy. But if you had a low prostate health index score, you have a less than 10% chance of being diagnosed with prostate cancer. So you may want to defer your biopsy or follow it over time. Yes?
Is there a blood test also?
It's also a blood test. So it's easy to get, it's easy to obtain. It is available nationwide. It is FDA approved. It is one of those that I always think should be the next step screening tool before you proceed to a biopsy.
It's not the norm around the country.
It is not the norm necessarily anywhere except for people who are urologists and even primary care docs who are a little bit more aware or who focus in on prostate cancer. But in real time, this prevents up to 2/3 of biopsies. I love this test. Patients love this test. And those guys who are not getting biopsied, it's because they don't need a biopsy. So it really helps stratify your risk. This is just additional data. This is from the company who makes it, called Beckman Coulter, which really, if you look at PSA and the performance here, it doesn't perform that well. But if you use the prostate health index, the type of cancers that you find and the frequency that you find it are a lot higher. So it's doing what it should do, which is to find cancers and significant aggressive cancers.
The PHI test presumes that the prostate is still in place.
You need the prostate to be there. It's more for the decision-making process after you've been treated, specifically with surgery. That test has very little value because it should hopefully be 0. And metastatic disease, it's going to be high. So let's say that ultimately we get some of these tests, we undergo a biopsy, and we're diagnosed with prostate cancer. So this is a very common situation, especially in my world. And the thing that I look at men and try to remind them is, yes, it's cancer, but prostate cancer is very different than any other type of cancer. Take a deep breath. Take the time to gather your information, make the most informed decisions. It's very rarely urgent. I can't tell you how many guys come in and a urologist told them, you gotta get this treated within a month. You gotta get this treated within a few weeks. No, take the time, get your facts straight. It is very rarely urgent. Don't let family and friends and doctors convince you otherwise. Multiple studies have really shown that as long as you're treated within 6 months of a diagnosis, it really doesn't impact the long-term cancer outcome. Rare studies suggesting aggressive cancers may benefit from earlier treatment within months. Most studies say you have at least a 6-month window. That's why, and I'm apologizing for my voice, but it's take your time, make your decisions. It's important to understand the options, get second opinions. It is not wrong, no one is ever offended. Talk to people, get as much information as you can. We can make more informed decisions by looking at your PSA, looking at your clinical stage. Is that confined to the prostate? Has it spread? Looking at your Gleason score. The Gleason score, which I'll talk about in a second, is just our measure of how aggressive in the microscope that cancer looks. But we can also use PSA density. How high is your PSA compared to your prostate size? The number of cores which have cancer, the total millimeters of cancer in any core. If you had an MRI, and if there's any tissue biomarkers, those can also help guide our decisions for what type of therapy you may need. And so one of the things that people have recently started to do is to use these tissue biomarkers to use what I call a genomic signature. So these are looking at, you had the biopsy, and they look at proteins that are expressed within the tissue. And based on the levels of certain proteins, they'll say, what are the chances of you doing well with active surveillance or with surgery, et cetera. And so these are just some of the tests that are out there, Oncotype, Prolaris, Decipher, that can help us make more informed decisions. One of the other things that we tend to focus in on, and still one of the most significant predictors of how aggressive a disease is, which dictates what type of treatment you need, is the Gleason score. So the Gleason score, again, is just a pathologist's way to tell you how aggressive the cancer is. So Don Gleason was a pathologist who described the architecture based on 270 cases. This was back in 1960. And it's amazing that today's era, that is still the same system that we use to tell us how aggressive a tumor is. There have been other competing classifications, but the Gleason score continues to be the #1 system we use, and it's been modified over time. But if we look here, the Gleason score really goes between 6 and all the way to 10. And if you have a score of 6, we now call that a grade group 1. If you have a score of 7, you either have a grade group 2 or 3, and there's some details here. And anything that's high grade, meaning Gleason score 8, 9, or 10, is going to be a grade group 4 or 5. Okay, but this is all still based on the Gleason score. And the higher your Gleason score, the more likely it is that you're going to necessitate treatment in the form of surgery or radiation.
Is there any significant difference between a Gleason 3-4 and a Gleason 4-3?
Yes, so they both equal 7, but a 3-4 tends to have more of the properties of a non-aggressive tumor, and a Gleason 4-3 tends to have more of the properties of an aggressive tumor. So even though they both equal 7, in the newest system, that's why they divided into grade group 2 for grade group 3. Most urologists, radiation oncologists, and medical oncologists would say that this is the cutoff. Anything greater than grade group 3, 4, 5, you are going to need definitive treatment. Grade group 1, we probably don't want to treat you. Grade group 2, some, if you're low volume, we probably don't have to treat. So when we talk about grade group 1, also known as Gleason 6 cancer, this is kind of the wimpy cancer that we talk about. It tends to be one of the most commonly diagnosed in the era of PSA screening. But the question is, should it be labeled as cancer? So what is the biology of Gleason 6 cancer? Does it meet all the criteria of cancer itself? Should we even call it cancer in today's era? And so the debate is, does it meet the molecular and clinical definitions of cancer? It does. It does have sustained proliferative signaling. It does evade a lot of the things that, it can grow on its own, and it can replicate. The one area of debate about it is, what is its ability to metastasize, to spread from the prostate? And if we look at the clinical outcomes, and again, historically, we treated all men with prostate cancer. So we have a lot of data here that says that clinical outcomes of men with Gleason 6 cancer, if we look at large data sets, 19,000 men who underwent surgery for Gleason 6 cancer, 57,000 men who underwent surgery for prostate cancer. And those who had Gleason 6 disease, we can see, does it spread outside the prostate? Can it spread to the lymph nodes? And the rate of positive lymph nodes for someone who's truly diagnosed with Gleason 6 cancer is between 0.1 to 0.2%. So very low risk. Go ahead.
Just a quick question. If Gleason 6, is a bit deceiving in my mind, because if you do a radical prostatectomy with it, 40% of the time when the prostate is out and biopsy,
It's going to be higher grade.
it's going to be higher.
So you are correct.
6 is a crapshoot.
So that's what you're acknowledging is the ambiguity of all of our prostate cancer decisions. So a biopsy is our gold standard, but there's a 30 to 40% difference between the biopsy and a final pathology. So how do you know what you really have? Should we just overtreat a lot of guys, 60%, just based on that fear? And that's really, just going through here, it doesn't spread, because I'm going to get to that point in a second. It's a very, very low risk of spreading if that's all you have, okay? But that begs the thing, do we treat all men with Gleason 6 cancer? Is it safe to follow them? Because that's what the biopsy is suggesting, that you only have a low-risk prostate cancer. And so that's where about 15 years ago now, we sat in a room and came up with this concept of active surveillance. Active surveillance is considered now standard of care for men with low-risk cancer. It's a safe, reasonable alternative to it. And the pros is that you avoid over-treatment. because we're taking those guys with low-risk cancer and saying, hey, the best information I can gather, this is not going to progress or spread. But the downside is, if you're one of those guys who have a more aggressive cancer, I may be missing a window of opportunity to treat you. I may cause increased anxiety with every biopsy because we actively follow you over time. You may develop an infection. You may have adverse events from the biopsy. So there are some cons to it, but I'm not over-treating you. I'm not exposing you to the potential side effects of definitive treatment. So we have, certainly in the Chicagoland area, the largest active surveillance program. We've had this since 2009. There are on study protocol over 630 men that we follow. There's an additional 200 to 300 that are off study that don't want to be part of the protocol. But if you look at men who have been enrolled all with low-risk cancer, that only a sixth of them have been treated over time. So men have done extraordinarily well. 3 have developed metastasis. But if you look at these 3, they didn't follow up accordingly, so it's more that they weren't following the protocol. No man has died of prostate cancer in this time period. From a prostate cancer perspective, that's pretty good statistics. On the other hand, you're right, there will be more men progressing. We are actively following them, catching them at a time we believe that is still treatable, but we're intentionally delaying their treatment, and for most of those guys, hopefully avoiding their treatment entirely. What about men with higher grade prostate cancer? There's a whole myriad of treatment options, from surgery to radiation to seeds, protons, hormones, newer therapies, which I often consider experimental, HIFU, cryoablation, etc. Each one has their potential risks and benefits. But if we talk about radical surgery, these days, I believe the gold standard is robotic surgery, minimally invasive surgery. This is going to enhance your recovery, make it a lot shorter. This is going to have your potential return of functions, your continence, your erections come back earlier. Robotic prostatectomy usually involves, because we're talking about higher risk disease, also an associated pelvic lymph node dissection. You're usually in the hospital for one night. Most guys are usually, we now are admitted for 23 hours. The expectation after surgery is that you're treated and that your PSA becomes undetectable. Although, if your PSA would continue to rise, or you were found to have an aggressive tumor, some men may benefit from adjuvant or additional therapies, radiation or hormones following that surgery. The long-term risk of having ability to hold your urine, 95 to 98% of men, depends on the surgeon, will be able to hold their urine after surgery. That's pretty good, and that's certainly much improved compared to traditional open surgery when we look. The erections, which is the other main concern that we worry about, is really largely related to several factors. Your age, the older we get, those nerves kind of degenerate. So if you're older having surgery, your chance of having return of function is lower. But if you have good preoperative erections, you should have good postoperative erections. Those go hand in hand. Most men will have return of erectile function. Most of these numbers are really derived from national data sets. There is some bias there, but the most important thing to undergoing surgery is based on surgeon experience. The more experienced your surgeon is, the less likely you're going to have side effects from surgery.
I have a quick question about the 23 hours. It's like an odd number in the hospital. Is that an insurance break?
You're usually covered for 2 to 3 days based on insurance. But these days it's just, you're put in as 23 hours.
Okay.
So what are the side effects? Urinary function If you look, again, these are national levels, but or national data, about half of men will be immediately continent after their catheter removal. But time and Kegel exercises will improve continence in these men. The median time to continence is really 2 to 3 months, but it can take up to a year to fully recover your continence. Dr. Albaugh will talk about this in more detail. And certainly sexual function, I'm going to defer to him as well. But again, about 20% of guys immediately will have a normal return of erections. The average or mean time to erection return is 6 to 8 months, but it can take between 2 to 5 years following surgery to fully recover your erectile function. And this is really based on, again, surgeon experience and the ability to save the nerves during the surgery. Moving on to radiation, the other alternative. Many different forms of radiation, which we're not going through today, but there's standard radiation known as intensity modulated radiation therapy, proton therapy, seeds, etc. But they all will kind of have bleed through and potential side effects to other organs that are there. So if we look at early side effects that happen right after you have the radiation, you rarely cause bad incontinence. Most guys do fine right away. If you do during the actual radiation, men may complain of increased urinary symptoms in terms of urgency or frequency, and about 10 to 15%, this will be bad, that they need medication or some change in management based on that. Over time, about 20% of men will have a significant decline in their erections based on the radiation. And bowel function, about 5 to 10% will have rectal urgency and frequency, incontinence, rectal pain, bleeding, etc. over time because of the radiation. And other causes or side effects of the rectum as well. And so this slide is really difficult to see, but if you look up to 2 years following the radiation, ultimately there's about 50 to 60% of men who will have changes in their urinary symptoms, bowel symptoms, overall quality of life after radiation. That's why if you don't need radiation or you don't need surgery, we try to avoid it. So if you have a non-aggressive tumor, that's what we're trying to avoid. And finally, again, these are all areas that deserve their own hour lecture. Hormone therapies. We've made a lot of advances in hormone therapies. Prostate tumors themselves are really sensitive and responsive to testosterone. If we get rid of testosterone, it blocks their growth. It causes regression of the prostate tumor. It never fully cures you. If we use it alone, it's not going to cure you. However, we use it to control it, and we can extend your life for long periods of time or control the tumor using these hormone therapies. Again, because of their side effects, we're essentially putting you through a male menopause. We generally reserve them for men with advanced or metastatic cancer that has already spread to the bones or lymph nodes. And sometimes we use it earlier on if you have a high-risk aggressive Gleason 8, 9, 10 tumor, and we pair that with radiation. But again, it can help control that advanced prostate cancer. Again, the side effects of hormones are many, but many men will have decreased interest in libido or in sexual activity. That's because testosterone really drives that. In and itself, it'll increase your risk of erectile function. It can associate with hot flashes. About a third of men will report significant hot flashes during the day. All of a sudden, they will experience profuse sweating. Over time, the lack of testosterone eats at your bones, so we have to monitor and make sure your bones stay strong. We encourage you to continue to work out because it also causes you to lose muscle mass, physical strength. It changes your normal cholesterol metabolism, makes you more susceptible to diabetes, increases weight gain, etc. So it's something that we pay attention to. And again, this is just one slide here, but we standard have many therapies, Lupron, Casodex, that get rid of your testosterone. Within the past 5 to 10 years, there has been an exorbitant number of newer therapies that are really designed to act on your hormones that will also contribute to increased longevity of life. So this continues to be an active area of research, but an active area for men with advanced disease. So many of you are familiar with many of these advanced therapies and are, but you should expect to see many, many more in the upcoming years. And so to leave you with a few messages here, make sure, be proactive about your health. Make sure you're seeing your physician annually. Engage in regular exercise programs and diet programs. Know your risk for not only other cancers, colon cancer, lung cancer, etc., but certainly for prostate cancer. Know your family history. Know your race, obviously. Engage again in those diet and lifestyle healthy alternatives. Again, PSA continues to be a useful tool. Talk about this with your physician. Make sure that it's something that you're engaging with, understanding. If it's high, make sure and repeat that blood test. Consider alternative blood tests, the Prostate Health Index, 4K score, etc. If you are diagnosed with prostate cancer, don't rush into a treatment decision. Talk to people. Get as much information as you can. If you have a non-aggressive tumor, consider active surveillance. But if it is aggressive, consider the appropriate treatment that would be right for you based on your age, your risk of the side effects. And with that, I'm going to save the rest of my voice, but I'm more than happy to answer any question.
Thanks so much, Dr. Helfand. So we have time for some questions. The only reason I have the mic is so we can pick up the audio for our webcast viewers. So please wait till I get to you with the mic before you ask your question.
Thank you. That was a very informative talk, and I enjoyed it a lot. I do have one question. You had that one slide where you had a lot of other tests that can be done now in addition to the PSA test before biopsy. And I haven't heard a lot about that, and I've been very active in this community. So is that something that you know about, or do all urologists know about it? Are there any professional organizations that are promoting these tests?
A lot of urologists know a lot about them. Their actual use is variable geographically and varies somewhat by physician. And a lot of that comes down to the fact that not every urologist is specialized in prostate cancer, but prostate cancer is a very common disease that most urologists treat. That's why it sounds a little self-serving, and I don't mean it in that way, but I always encourage, if you're diagnosed with prostate cancer, make sure you are with someone who is specialized in that area, because I do think, or even before diagnosis, because there's a lot of insights that can be used and a lot of unnecessary procedures that can be avoided if you're paired up with someone who's knowledgeable in it. But I do think that that area is expanding. And I would say, the two most common tests in that setting right now are the Prostate Health Index, the 4K score. There's MDX Health has the prostate, I'm just blanking on the name right now, but there are, in that setting, different blood and urine-based tests that can help. That PCA3 was another historic one that was used. So there are tests that really can inform your decisions.
Yes, I'd like to know, why is there such a disparity between physicians when they prescribe using a anti-androgen such as bicalutamide in conjunction with Lupron, and then there's a mindset within some physicians that while you might want to initially start with the anti-androgen, but you want to not continue in taking something like Lupron in conjunction because it might turn off the inhibitors within your system, and certain doctors are prescribing that, and that could have a significant impact on your your quality of life and your ability to recover.
Right. And so just to kind of reinstate that question, because it's somewhat of a complex question, but for men who are receiving androgen therapy, there's not a universal protocol, if you will, of what we all are following, meaning that some urologists, some medical oncologists, radiation oncologists will use it. They'll use various forms, oral pills, Casedex. Some will use Lupron kind of shots in the behind. Some will pair it with some of the newer generations, Zytiga and enzalutamide. And so it's not standardized. And half the reason for that is that the clinical trials that have been done aren't standardized. We don't really know what is the ideal length of time that a man should be on hormone therapy if you're pairing that with radiation. Is it 2 years? Is it 3 years? Is it 1 year? And so there's variability there. We do know that depends on, again, the side effects. Casedex may have certain side effects, less hot flashes. Lupron has more, and so that's often not discussed with patients. And so it is kind of bringing those matters up and saying, hey, what is the rationale? Why are we doing this for 2 years? Why can't I go on intermittent hormone therapy, get my PSA lower, take a little break, recur? Because I want to feel like a guy for a little bit, again, without those hot flashes. I want to enjoy a lot of parts of my life. Those discussions should be had, but it's going to be somewhat individualized because as a urologic group, if you will, we don't have a set of standards that is universal. And that's our fault in the way studies have been designed.
In conjunction with that response, it's my understanding, speaking with multiple physicians at multiple institutions, that the basis for prescribing any hormone therapy, especially depending on low, medium, and high risk, is really predicated on a trial that was done 15 years ago. And so is there going to be any indication that something's going to be done, because it's really a limited sample size, and personally reading the trial myself and understanding that they're prescribing everybody who's getting hormone therapy on this trial that
Right.
existed so many years ago?
There are trials underway. Again, they're certainly modified. The issue with any trial, and this is somewhat the beauty of prostate cancer and why I really love treating it, is men do very well, even with advanced prostate cancer. Yes, it can go on to kill a lot of men, but in general, to get that data, to follow it, and actually determine if that's correct, you need to have a study that goes on for about 20 years. And so any study that's why we're still referring back to historic studies, is because we only have that data on those historic studies. The newer studies are still coming forth. So we still won't be able to make definitive recommendations for a long time. Now, because we're accepting other things other than death as an endpoint, meaning metastasis, how your scans are looking, we're starting to incorporate that into a lot of outcome data. That may give us answers a lot faster, but it's still coming forth.
We have time for one more question, and we wanted to bring in our online audience too. We got Tim back here, who's doing social media and monitoring the comments from the webcast. So I'll turn it over to Tim to relay a question that we have from our online audience.
Is there any form of ADD treatment, an equivalent that does not steal your libido and deprive your body of a much-needed hormone, testosterone? I've chosen to quit ADT after 16 months since diagnosis. The side effects for me have been toxic and life-stealing. I'm 66 years old with stage 4 node-positive cancer, had radiation at 81 GY. Right now my PSA has been at near 0 for 9 months.
So that's if you didn't hear that, this was a gentleman who wrote in and really described his experience of being on hormone therapies. Is there alternatives to hormone therapies that don't have those same side effects? Unfortunately, a lot of the therapies and the response to prostate, just like breast cancer is responsive to a lot of estrogen therapies, prostate cancer is responsive to a lot of testosterone therapies. And that still tends for men with advanced cancer to control it, keep it under control, and again, paired with other things. So right now, even though we're exploiting other chemotherapies, immunotherapies, it still tends to be the mainstay. That's why if we can avoid it and avoid men from progressing to that stage, we want to avoid it. It's what makes prostate cancer so challenging, because we don't want to overtreat you, but if you have cancer, we want to prevent you from ever getting advanced cancer. So there are just so many little details on the way that make it so confusing to do. But unfortunately for men with advanced cancer, that still tends to be the mainstay therapy, are getting rid of your testosterone, driving that down.
All right, thanks so much, Dr. Helfand.
Thank you.
Appreciate it. I believe you'll be around for questions during lunch.
I'm around for a little bit. Thank you.
So now we'll switch over to a discussion on ED and sex after prostate cancer with Dr. Jeffrey Aubaugh. Dr. Aubaugh is a board-certified advanced practice urology clinical nurse specialist, board-certified sexuality counselor, director of sexual health at North Shore University Health System and at Jesse Brown VA Medical Center, and a member of the US2 Board of Directors. So we want to thank Dr. Aubaugh for not only presenting here today and sharing his expertise, but he's also providing a free copy of his new book to everyone here. So please be sure to pick that up too. So join me now in welcoming Dr. Aubaugh.
All right.
I can set those up.
Yeah, just set them on the table. It's fine.
Sure.
All right.
Answer.
Yes, I'm going to clean it. All right, I'm going to sanitize a little bit because my colleague has been sick since I was with him in clinic on Wednesday, and I really don't want that cold. I don't want to sound like that. I've got a conference in Miami, and I don't want to sound like that when I go. But I do really appreciate his excellent talk, and I hope you did too, because you don't often hear a surgeon talking about reasons not to do surgery, and I think it's important for you to know and understand those things. So it was excellent, and I enjoyed it as well. So thank you so much for being here, and I look forward to sharing my expertise with you. And if you have questions, certainly I'm going to stay around through lunch, so I will stay to answer your questions. If you want to ask me something individually, I'll be happy to do that. And we will have a book for each of you, and even there's some extras. So if you, all I ask is that you either use it yourself or pass it along to someone else who really needs it, because we just want it to get in the hands of the men who really need the information. And so I'm happy to share it with you, that's for sure. I'm going to share a couple different quotes with you. I did want to tell you we do support US2. So North Shore did, as a corporation, support US2 at the Sea Blue Walk. And we did raise over $4,000, our team. We did fantastic this year. So I was very excited about that. And the Sea Blue Walk was amazing. Those of you who were there, thank you. I'm going to share a couple quotes from the book and go through a few things. So I want to start with some of that, just so you understand. Everybody's different. Probably if we went around the room to see how everybody felt about sex and intimacy or what they thought was important, we'd get every single person would have a different view and a different paradigm, a different way of thinking about it. So when we talk about these things, you may feel differently, and you'll hear some of the things that occurred with patients. I'm going to share a couple quotes, and I'm going to share back-to-back 2 quotes that are very different. This is one man's experience. He said, "I was not prepared for what was to follow. No doctor informed me about what I should experience and what I'm going to face with challenges. I think everybody, all the medical staff, starting with the nursing and support staff and the doctors themselves, they really need to inform the patient with what's going to happen after surgery, with complications and side effects on the surgical end and the physical end. But also the effects from the surgery should be talked about from the get-go, so that patients are not surprised, that they know what's going to be heading their way. Give them the full information. I'm very, very emotionally upset about it, because if I would have known, I think I would have been in a better place through the first year and following that year after that. So you can hear some experiences are going to be more challenging, and some people feel they didn't have the information they need. And that's where I think us too is so important, because you need to gather your information from a variety of sources. But everybody's experience is different. So here's what another, and I have to thank what we did with the new edition of the book was put the patient's voice in and the partner's voice. So I am forever grateful to all the men, including many people from us too, who participated in my study and shared these incredible quotes and information with us. So another guy said, I was fully informed by everybody. All the doctors that were involved fully informed me that these were the things that I was up against if they removed my prostate. There's a lot of things that are happening to a person in my situation. So definitely, you definitely must keep everybody informed about what's going on. It's extremely important. I think because she, the partner he's referring to, had all the information. She read the books that I was given, so she knew exactly what I was going through. So everybody's experience is different. And the same thing with sex and intimacy. Everybody's experience is different. My experience is different than yours. So you have your own way of thinking of it and your own way of looking at it. And nobody's opinion matters except yours and your partner's, if you have a partner. That's important too. So let's get started with some of the information I want to share with you. And so if we talked about what is sexuality, what is intimacy, they're two things that are directly linked together, but at the same time, they are two things that are distinct from each other. But I want to talk about both because they're really important. And if you go back to watch the videos, because they've created a great video library of these pathways events, you will see another of my colleagues talking about more about intimacy and some really great things from Dr. Ann Katz from the New Jersey Pathways event. So there are some great resources, so please look back at those. But if we think about sex, if I said, what is sex? And each of you gave me your definition of it. Can anybody give me a definition of what you think sex is? No, none of you think about sex. We shouldn't even be talking about it, right? Okay, forget it. Let's go home. Let's go to lunch. I'm the only thing keeping you away from lunch. All right, so if we talk about sex, we know that it's some things we're born with. We're born with genetic coding for certain sexual things that happen to our bodies and in our lives. Some things, but it is multidimensional, and it changes. What you thought sex was when you were 6 or 8 and what you thought it was at 30 or 60 or 80, they're going to be different. So it's dynamic, it changes, and it's individually and culturally derived. How do we know that? Isn't sex the same across the board? When we look at sex, how people view sex, or when they start being sexually active in China, the age is actually statistically significant different from the age that people start having sex in the United States. So it is culturally derived. What we think about it comes from everything. When patients come in my clinic, I ask them everything in the universe. And sometimes they may think, well, why do we have to talk about all that? But everything affects sex and intimacy. Sometimes your religion, sometimes your culture, sometimes your health, many, many things can affect it. So many things affect that experience. But some people think of what sex is that sense of being male or female. When we talk about sex today, we're talking about the acts of sex, and it has anything to do with any kind of genital stimulation. Much difference in some of the definitions of some of our previous presidents, but anything that has to do with genital stimulation is sex, not just intercourse. Sex is that collective group of things we do for pleasure that we do with genital stimulation. And so that's what we're talking about with sex, is genital stimulation and pleasure derived from that. Intimacy, Hatfield says, is that process by which two people attempt to move towards more complete communication, more in-depth, complete communication with each other. Communication on all levels, physical, emotional, verbal, all different levels. That connectedness that can occur is very important, and that's intimacy. Okay, so we have a radical prostatectomy. You've heard some things about that already from the past lecture, but basically what I want you to know is what happens with sex and intimacy. Remember, the prostate sits below the bladder, and it's a vital organ of your sex and reproductive system. So of course, sex and intimacy is one of the things that's going to take the main hit when we take your prostate and seminal vesicles out, which will be done with a radical prostatectomy, or if we radiate your prostate, or if we give you androgen deprivation therapy. Androgen deprivation therapy also is going to diminish your testosterone and affect sex. So any treatment that we give you for this, even patients in active surveillance over time start struggling with erections, because as they get older, they have other problems. Sometimes diabetes or high blood pressure or just aging can affect sexual function a bit, depending on how good of shape you stay in as you get older. So even with active surveillance, one of the big complaints long term is sexual side effects. So I think that's really important for us to remember. And when we look at the truth of it, and as Dr. Helfand said, so men get back sexual function. In our recent study that we haven't even published yet, we found men started with pretty good sexual function before they got their prostate cancer treatment. Afterwards, the sexual function, we looked at their scores. Their scores, when we add up all the questions we asked them about sexual dysfunction, were very low right after surgery. But when we looked at them at 3, 6, 12, and 24 months later, the scores got better. They were functioning better. So erectile function in particular did get better in most of the patients. But the bottom line was very few of the patients got back to where they were functioning at the level they were before. A little less than 30% of the patients at 1 and 2 years were still struggling and not back at the scores that they would have been before they had surgery. That's important because when we look at can you function sexually, we look at a very strict definition. Are you hard enough to can you get and keep an erection to get through whatever kind of sexual experience you're trying to have? Isn't that the demarcation that really defines it? So if you have a partial erection and you can't do what you want to do during sexual relations with your partner, you still would say, I am not where I want to be. So if we use that hard line, that's when and everything you say, and here's wrong. Here I'm saying the hard line or the hard, everything you say has a double intendo when we talk about sex. But bottom line is, we find out that 78% at 2 years and 72% at 5 years were struggling with erectile dysfunction. Now, some may have had mild, some may have had severe. But remember, this is a group of people that are about 68 or 69, so a good 40 to 50% of them would have had problems anyway. So don't compare that to 0, but it's still, the numbers are very different from 40 or 50%, even 60%, 78 and 72%. 8 out of 10 and 7 out of 10 were still struggling. This is a 15-year study with radiation, and we find very similar outcomes over those 15 years, that most men are struggling with erectile dysfunction, whether they had radiation therapy or whether they had surgery. And in fact, when you look at some of the studies that compare the two, a pretty equal amount. Either way you go, the number one thing is sexual dysfunction, and you have a pretty equal chance of getting it either way you go. Now, sometimes it's not as severe, especially in the beginning with radiation therapy, but you have a pretty equal chance of getting it, whichever way you go with treatment. And the two main treatments to get rid of and eradicate prostate cancer are surgery or some form of radiation, whichever kind of surgery or radiation you do. So erectile dysfunction is the ongoing problem, and that's why today we're really focusing on that specifically. Again, just more statistics to remind you, erectile dysfunction is the issue, whether you have surgery or radiation, and the majority of men, the huge majority of men, the truth is they're going to struggle with erections after prostate cancer treatment with either surgery. You just heard about androgen deprivation from Dr. Helfand, but I just listed out the weakness, the bone health, all the different things that can be affected a little further so you can know those things. We are thankful that we have these treatments and that over the last decade we have like 7 more treatments, but they're all treatments that are focused, as you heard from the question, at lowering testosterone to try and manage prostate cancer rather than cure it. And curative things are surgery and radiation. And then you heard also, it doesn't always have to be treated. That's important too. So how does prostate cancer affect these things? Lots of different ways. So the most common side effects, whatever you do, we've already given you that information that you're going to probably have sexual side effects with treatment from prostate cancer. Ejaculation, remember, the sperm travels up from the testicle. It travels up in the epididymis where it actually matures, and it travels up and mixes with the fluid that comes from the seminal vesicles and prostate. The most of the fluid that comes out comes from the seminal vesicles in the prostate, and those are going to be taken out with the surgery or radiated with radiation. Either way, now you're probably not going to ejaculate fluid when you climax. When you get the orgasm climax feeling, it will probably be dry or very little will come out. Even with BPH as you get older, your ejaculate will not propel like it used to. It also will not come out in the volume that it used to. A lot of men complain as they get older that ejaculation sort of is diminishing, even though the sensations and feelings are there and feel good, even with benign prostatic hyperplasia, not just prostate cancer. So ejaculation changes, and that changes dramatically after surgery and radiation. The penis can sort of retract, like the turtle's head retracts up into the shell. It sort of disappears. And it's like, what happened? Where'd it go? You know, I mean, it literally can feel that way to some men. I've heard them describe it that way. Most men talked about this for years. In my group that I ran at Northwestern over 12 years, men talked about it all the time. But in the research, the doctors kind of said, I don't think so. That's not possible. The pelvic floor is set. It can't be. And they did find that, yes, it is true. Studies actually showed. Now, it's only average about 1 to 2 centimeters, but some people notice it dramatically. Some people don't notice it at all. But penile shrinkage is something that can happen, and it's usually transient after you have a prostatectomy. Now, if you don't get back erections again, you could have muscle atrophy and more permanent, but I'll talk more about that in a minute. So a lot of these factors can affect your life. They can affect how you relate to yourself and how you look at things. Another quote from a patient that I'd like to read you, and everybody's different. I certainly have men who've said to me, you know what, this is not a top priority. I'm not real worried about it. I'm not real concerned about it. So that's okay too. And if that's where you are and your partner okay with that, there's nothing wrong with it. This patient said this: if you have a lack of sensation, you don't have any nocturnal erections. You don't wake up with an erection, and I miss that. I miss it a lot. I miss the sensations of how I used to feel down there, how my body used to feel. I don't feel whole, and I think about it every single day. It's the first thing I think about in the morning when I wake up, and it's the last thing I think about at night. I miss it. I wish I could have it back. Some of the women in the audience might be thinking, my gosh, it's a penis. I mean, really, it's like if some things don't function. As a man, all of us, from the day we were born till it stopped working right, having erections is a part of life. It happens every single day, usually 4 to 6 times a day, from the day you're born till it stops working right. The penis is literally erect about 2 to 3 hours out of every 24-hour period. So it's not just about sexual function, it's about function in something that a man has had his entire life. Sometimes we like to think, well, it's not going to affect me that way. I'm bigger than that, I'm better than that. But when you live it, sometimes it does. It kind of tears apart your world and how you look at yourself, and you think about yourself differently for some men. Some men, it doesn't do that. It doesn't mean that anything's wrong with you, and it can be frustrating because you're like, I don't have cancer. Hallelujah, that's an awesome thing. But at the same time, now I'm struggling with this. And life after cancer treatment sometimes can be devastating too. And actually, we hear people quoting, and I'll quote a couple other things that people said here, and surprisingly, you hear people actually talking about treatment regret, people talking about regretting their treatment. One man said, I think back, maybe I shouldn't have done it. And I go with a shorter quality of life rather than a longer life with this situation. One partner said, because he would always say, maybe I shouldn't have done that, the radical prostatectomy. Hold on. And I'm like, you did it. So let's live on, not live in the past. It got better, yeah. He felt like he didn't want to live because he didn't feel like a man. He felt like, oh God, this is a mess. Now, not everybody feels that way, but if you feel that way, you're not alone, because some people do feel that way. We talked about the penile shortening. Mostly we think that happens when we look at the science because the pelvis is fixed from increased muscle tone right after surgery. Right after surgery, everything's sort of like, whoa, what was done down there? And the muscles sort of tense, and we have increased sympathetic tone, and that's what the initial response is from, and that is usually transient. But if you don't start getting regular erections, remember, in your penis is lots of muscle, smooth muscle surrounding blood vessels. The smooth muscle relaxes, the blood vessels fill and you get hard, the smooth muscle contracts back down, and the erection goes away. The blood goes back into your body. So that's important. In fact, let's go over that just a little bit. How does a normal erection occur? When you get excited, it's all put together in the brain. The message goes down the spine to the peripheral nerves. Peripheral nerves come off your tailbone, bundle on the right, bundle on the left, and go to the penis. When the signal gets to the penis, it activates chemicals directly in the penis that cause the smooth muscle to open up or relax so the blood can engorge and fill the penis. You get 7 or 8 times more blood in there, and that's what makes it hard. So you need nervous conduction and blood flow to get erections. But when they do the surgery, they literally peel the nerves off the back of the prostate. And even though they spare them, they were never meant to be healed. Thank God nowadays they almost always spare them so they have a chance to recover or regenerate, but they were never meant to be touched. So initially, they become traumatized, inflamed, and they can take up to 5 years, an average of 2 years to recover. So that's an average of 2 years. Nerves are interminable. I started my whole career with spine injured patients who had bowel, bladder, and sexual problems, and the nerves could take up to 5 years, average of 2 years to recover in them as well. So nerves take a long time to recover. And so the goal of penile rehab, you'll hear about that sometimes. Penile rehab is just trying to promote blood flow and nervous conduction down into the penis while we're waiting for the nerves to recover. Because 5 years is a long time, and we want to get the blood moving down there and blood flowing down there. But I will tell you that the results of penile rehab, especially with pills, are very mixed. And in fact, the new AUA guidelines from this year say we have to tell you that in general, we don't know whether it will help you to take those pills regularly or not, because the studies are very conflicting about will it or not. What I think is most important is trying to get the blood moving in there regular in some way, shape, or form. And if the pills, because they don't always do that much after surgery, aren't doing enough, then you use the vacuum pump, you use something else like injections or mousse or something to get blood moving in there better, and that may help with rehab. But the truth is, we don't know how much it will help or not because the studies are conflicting. It seems like there are studies that say it may help, but there are also studies, especially with the pills in particular, that especially don't always work after surgery, that say it doesn't always help. Intermittent versus regular use of them versus not using of them, it's mixed. Most people think at least intermittent to regular use of them can be helpful, but we don't know for sure. So penile rehab is still sort of something we're not too sure about. So, what's sex and intimacy about when it's no longer about reproduction? In my 50s, my wife and I, we're not having sex because we're trying to have kids. God knows that's not why we're having sex, because mine are going to be 23 and 25. So we're done with those days. But the bottom line is, people are still having intimacy because of connectedness, feeling connected to each other. Remember that intimacy involves communication on all levels. If you have a partner and they've lived through prostate cancer with you, you know. I always think, who's it harder on? The person experiencing the prostate cancer or the one who loves them and feels helpless trying to help them get through that experience? I don't know. I think it's difficult either way with any life-threatening illness, so I think it's really difficult. But isn't that the time that you desperately want to feel intimacy or connectedness with your partner? When you're dealing with something like cancer or the difficult things that come in life, like loss of loved ones and all the things that can occur during our lifetimes that make us want to feel more connected to each other. I really do like Brené Brown's definition of connectedness, and I think it kind of captures intimacy. It's the energy that exists between two people that feel seen, heard, and valued by each other, that you can exchange information between each other without judgment, and I think that's really, really important. Who doesn't want that? I want more and more of that. How about you? Do you want that too? I'm guessing you do. Who doesn't want it? Sign me up for a double dose of connectedness. It's good. Pleasure. Sex is supposed to be fun. One lady told me, the minute he takes the blue pill, my blood pressure goes up and I'm a nervous wreck. And I'm like, oh my gosh, really? That's not what this is supposed to be. It's supposed to be fun. And he's like, then it doesn't work. One guy told me, first off, he was doing everything wrong with his vacuum pump. He was laying down trying to use it. I'm like, why are you laying down? Gravity helps. And he got upset and threw it across the room. I'm like, I mean, this is not pleasure. It's supposed to be fun. It's supposed to be enjoyable. But it's frustrating and it's upsetting when it's not working, especially when your whole life you thought it happened. Sometimes even when you didn't want it to, right, man? You know what I'm talking about, because sometimes the penis will spontaneously come up. You're like, oh, God, help me. You know, really? That's why you're like, I don't really want to take a shower with the other guys, because you never know when something's going to happen, and sometimes for no apparent reason. So pleasure, it's supposed to be fun, but it can be real anxiety producing. Intimacy is important, and so we got to think about things differently. So if it's about connectedness and pleasure, and I'm sitting on the sidelines thinking it's not like it was, I would rate this a 2. This is a 1. This is not working. I'm not as hard. My hardness on that hardness scale that he showed me is a 1. It's a 2. It's not what it was. You're not present. You're not there. You're not really experiencing this as it's going along. And how good is your memory of what it was? I mean, sometimes you think things were really fantastic, but you don't really recall. None of our memories are perfect. So why are you back comparing it? Because we do. And I probably would too, but you've got to step out of that, because that's not helping anything. So it's about connectedness, pleasure. What else? Sometimes orgasms can be really nice too, but all of that can happen whether you're hard or not, correct? You know that by now. If you've ever had erectile dysfunction, you know you don't have to be hard to have a climax or an orgasm, because they're wired separately in the peripheral nerve system. So you can have connectedness, you can have pleasure, you can have orgasms whether you're hard or not. Masters and Johnson, Kinsey, every researcher known to man showed women don't need a hard penis. They need nothing in the vagina to climax. It's about clitoral stimulation. It's about other things. So you can orgasm without a hard penis. Your partner can orgasm without a hard penis. Women and men can orgasm despite all that. So we can achieve all of this whether you're hard or not. But you can't have intercourse and penetrative types of sex with your partner. And that can be really enjoyable, and I completely understand that. But what I'm saying is, if intercourse is the tango, what about the cha-cha? What about the merengue? What about all the other ways that you could experience connectedness, pleasure, and intimacy, as well as orgasms with a partner? It's about pleasure. It's supposed to be fun. Don't make it not fun. And for God's sakes, like most of us, if you're having sex, it doesn't happen that often. Have fun and don't leave it, okay? It's not good. Stay present. Enjoy the pleasure. And there's many ways to experience sexual pleasure. Don't limit yourself. You and your partner will decide. There's oral stimulation, manual stimulation. Manual just means using hands or rubbing genitals together. There's vibration. The excitement comes from the anticipation, because as we're with partners, I've been married now for almost 33 years. We fall into different patterns. Okay, we're all busy, everything's crazy, so we know what works. We're gonna have sex. We got a few minutes. My grown children are coming home soon, because they still live with me, some of them, and so we got a few minutes. All right, what do we do? I touch you there, I touch you here, this works, that works, right? You're good, I'm good, are we done? Okay? It doesn't sound like fun, does it? Okay, so the bottom line is the excitement comes from maybe this time we won't have an orgasm. We'll just cuddle. Maybe this time you'll have one and I won't have one. If we're both okay with it, it's all good. Maybe we'll do it this way this time. And even women, definitely, and men too, they can change their mind. Yes, I wanted it that way yesterday, but today I don't want it that way. What don't you get about that? You have to be open and receptive to each other and see what do you each want and how can you get there. But intimacy is very important. We're all hardwired for intimacy. In fact, how many of you have heard of emotional intelligence? Have you ever heard of that? right? There's a whole book written on it. Well, there's a second book written by the same guy who pulled all the research together on connectedness, and he found social intelligence is also important, that we are hardwired to be connected to other human beings. In fact, babies will die if they don't connect to another human being. They call it failure to thrive. We are hardwired for connectedness. So we can kid ourselves all that we want and say, I don't need anybody, but it doesn't work. You are hardwired for it, so intimacy is really important. So we have different therapies. We have counseling. We talk about, let's think about things differently. I had a 70-year-old couple who came in and they were like, I don't know what you're talking about, Dr. Albaugh. We don't know any other ways to have sex. And what is a clitoris? Show us. What is it? So I did. I pulled out pictures, Google images, you can find anything, okay? And so I pulled up some great images and said, this is what the clitoris is. This is what you're going to work on. So the bottom line is sometimes that information can be life-changing for some people too. I had no idea. She may say to me that he could climax without an erection. He's always had an erection when he climaxed. Sometimes the men will call on the phone, oh my God, I can't believe what happened. I had a climax and I wasn't hard. Most of our men know that because they come see me before they have surgery, but not all men do, so they're a little taken aback by it. But we have vacuum pumps, we have pills, we have shots, we have all kinds of things out there to help. But the truth is, and this is what I hate about my job, this is the part that kills me every day with my job. I can't give you what you want. I'm going to fail every day in my clinic to give you what you really want. And that sucks. I'm just going to tell you, sorry. At least I know her. So sorry about that. But the bottom line is, I can't give you what you want. Because what you really want is you think it, it happens. You don't want to deal with any of this. I get it. I have to live with that every day in my job, that I can't really give anybody what they really want from me. I can just try to help them move to a better place and have a better life. But what they really want, I can't give it to you. And I hate that part of my job, but the truth is, it is what it is. So what are we going to do with what all of us have, and how can I help you? Well, here's some of the ways, but it can be challenging. It's not perfect. You know, you have to practice with these things every single day. You have to pull this vacuum pump out. You have to learn how to use it and be literally you have to be like Han Solo with his sword, right? Or Harry Potter with his wand, because until you master this, it's going to feel cumbersome. It's going to feel awkward, and it's still going to feel that way ultimately, because now you have to put your penis inside this vacuum, pump it up, and then put a band on. One of these bands that you put on the end has to be transferred to the base of your penis to hold it. So before you even touch the bands, we have you work every single day practicing, working, practicing, working. Be patient, practice, I tell you, over and over. And it's difficult. Then once you master how to get an even lifted off erection, we got to work with the rings. So there's pros and cons, there's good and bad. But what we do find is if you follow exactly what I tell you, and you do what we work on together, about 85 to 90% of patients will be able to get an erection. It's not like the old ones at all, but we'll be able to get an erection sufficient for intercourse. Now, it will feel cool to the touch. It'll look a little pinkish purplish if you're of Caucasian persuasion, and you may have to guide it in because your old erections were rooted in your body like the roots of a tree, and this one stops where the ring is, so it wobbles at the base. It's far from perfect. I'm just glad we have it, and I'm able to help people use it, and I have patients who embrace it and like it. I have patients who hate it, and I get why you hate it. There's things I hate about it. Remember, I wish to God I could give you what you really want, but I can't. So I got to work with what I've got to help you with what we've got out there. But remember, so then you say, well, I want to be spontaneous, and I'm in the middle of wherever, and I'm not going to get arrested for being naked, and we could have sex out there, but I forgot my vacuum pump. Can you have sex? If you haven't learned anything else today, you better answer yes, because you can still have sex. You can have connectedness, you can have pleasure, you can have orgasms together. You can't have intercourse maybe because you didn't bring your vacuum pump or your shots or your whatever. But when you want the spontaneity, it still can be there. But you say to me, that's not how I've thought about it my whole life. And I don't know how I would embrace it if I were you either. So I don't judge you on that. And I know it's really hard to shift the way it is and learn to live with the new normal and all of the difficult things that we're throwing at you. I just want you and your partner to be happier and to be connected and to have a good life, because you deserve it. You're a cancer survivor. And that's why I wrote the book, because I want to help you. But I still can't give you what you want. So I'm going to fail at what I'm doing with you anyway. But we try our best to at least get you a place where you're happier. So this is one way we do it. It's got its good, it's got its bad. But when they looked at penile shortening, they found using it regularly may help preserve penile length. It may help with some of the erectile function things. To put your penis literally in the pump and pump it up each day without rings and just do stretching. Let it sit in there for a minute or two. Take it out, put it back in. Let it sit in there a minute or two. Take it out, put it back in. Do about 5 of those. They don't know for sure because they're small studies, as you can see. But do these regular, we call them penis push-ups inside the pump, trying to get the blood moving in there. And remember, your penis used to do that while you slept. But in the absence of that, we're trying to replace it with some things that might help. And that's one of the things we do. So often the oral agents just don't work after surgery. This is getting really technical now, right? And it does, because I'm trying to give you all the technical expertise, and I'm happy to answer your questions about more technical expertise. But when we go back to the vacuum, there's all these pointers that I do with patients, and when I work with them, we work on how do you get it to work. Because if somebody just hands you the pump and says, good luck, the truth is about 80 to 90% of patients can't get it to work right. And they're like, what does he mean it works in 85 to 90%? It didn't work for me. Probably you didn't have proper education and proper work with somebody. It still is far from perfect, but it's a lot of things to get your mind around, and it's very technical. So the pills often don't work, especially right after surgery, during that period where the nerves are kind of inflamed and not working right. And they may over time start working, but they don't always work. So local therapies often work better, like vacuum pumps and shots. So the oral agents, there's lots of different ones, and a couple little pointers, and you have these slides so you can read this. I think you have them. No, maybe you don't. Well, anyway, you can watch this online, but the bottom line is I'll answer your questions about them, but there's lots of them. They all do the same exact thing. So it's not like this, if this one didn't work at all, none of them are probably going to work because they do the same thing in your body. But you may find, because they're slightly chemically different, that if they kind of all work, one works a little better than the others. That can be true, and one can push you over to better than the others do. But in general, they work the exact same way in your body, and so they work pretty equivocally when you look at the research. They all can have some side effects. There's a lot of things to think about with them. They all need to be taken on an empty stomach, and the classic 3 at the top will take about 20 to 30 to 40 minutes to even get in your bloodstream, and about 60 to 90 to 120 minutes to reach their peak effect. And then Viagra and Levitra will be gone in about 8 hours, and this one will be gone in about 36 hours. The newer one, Avanafil Stendra, gets in about 10 to 20 minutes and peaks in 30 to 40 minutes. Remember, all of them, even though some say you can take them with food, but especially Viagra is sensitive to food and fat, so really take that on an empty stomach. And over, patients with thousands and thousands of patients over the years have told me taking it on an empty stomach makes a big difference, and waiting a good hour or 2 for these 3 seems to help the best, in about 30 minutes for the newer one. And that one's gone in about 3 hours. I'm happy to talk about the side effects, the different things to think about, but I want to leave time for your questions, so I'm just going to leave you with knowing that part of it. And knowing a few other little hints. You can get generic sildenafil 20 milligrams with prescription. These are all prescription with a good RX coupon, which is available to anybody, for about 30 to 50 cents a tablet at places like Osco, at places like Costco, at places like Mariano's, CVS, different places. Walgreens, for whatever reason, you can't get that generic sildenafil 20 milligram tablet, but you can get that drug very cheaply. And although it's 20 milligrams and you may need 100, you can take 5 of those tablets to equal your 100 milligram, and that will cost you about $2 versus $86 for the blue pill these days. So that's one workaround that we've learned. You can get a generic version of the blue pill in 100 milligrams that will cost you about $30 or $40. They're all made by the same Teva company. It's an Israeli company, but you can get them through American pharmacies. There are American approved generic equivalents of that drug. There are now generic equivalent drugs of Cialis that you can get from your pharmacy too. It's called tadalafil, which is the chemical name. Sildenafil, tadalafil, those are the other names, and those are available in the United States now too for quite a bit of savings because these drugs are crazy, crazy expensive. But you can get generic equivalents of both Viagra, sildenafil, and Cialis, tadalafil. And that's what I wanted to say about that to give you a bit of information. This just talks about penile rehab, but I told you some of the biggest, best studies show that it may not make a difference whether you take it every day or you take it intermittently. It does, people do better than placebo, and when on the drug, people are definitely doing better. But with a washout period of staying off the drug, what we're trying to see is, are your erections better if you didn't use the drug before without the drug? And what they're finding is mixed results. When you're not on the drug, you may not have those good effects, even though you took the drug daily for penile rehab. So it doesn't always work. But some of the studies show it did work, and that's why we were compelled to tell patients to do it. But some of the studies show it doesn't, so mixed results. Just more studies to say penile rehab may or may not help. It's hard to say. The drugs are expensive. We get why you don't want to use them, and that's why we use generic equivalents now. Mousse is a little suppository that goes down the wet urethra. The big reason we don't use it all that much is they can cost a lot of money. They come in a box of 6, and when they don't work or you have side effects, you're kind of upset. Many insurances don't cover. Remember, Medicare covers none of these drugs. But if it makes those of you on Medicare feel any better, remember I split my time between the VA and North Shore, and my insurance comes from the VA, and I get the same amount of drugs you get for erectile dysfunction if I have it, because our Blue Cross plan is one of the only plans in the country. The federal plan does not cover erectile dysfunction medications. So these are not covered. They're expensive. They can cause some side effects, but I'm glad we have them for the men who they work for, which is only about 40 to 50%. I'm glad it's out there. I'm glad we're able to help people with it, but it has a limited efficacy, only working in about 40 to 50% of men with true erectile dysfunction. In my experience at least, and in some of the studies that is purported, I really don't think it works in the majority of men, but the men it works for, it's easy, it's simple. If it's covered by insurance, or you have a lot of money, it definitely is a possibility, and I'm glad we have it as an option. I just talked a little bit about how it's used for penile rehab a little bit, usually nightly, and again, small studies, but promising results, but small studies, and it could be expensive, of course, if you used it nightly. Injections, I've done a lot of injections with a lot of patients, just like I've done all these other things with patients. They have good and bad. Again, the positive thing is you get a more natural feeling and looking erection. You don't have that pinkish, purplish wobbling at the base like you do with the vacuum pump, but dropout rates are high for the injection, higher than even with the vacuum pump, because you have to give that shot to yourself. And even though I published one of 3 studies that say the needle doesn't hurt, it's a strange thing to do yourself. Some people can't get past it, and it doesn't work for everybody. There can be a good group of about 15 to 30% it doesn't work for. Those people aren't going to continue it, and some people do get side effects. But why do men do it? Why would anybody stick a needle in their penis? Because you get a fairly natural feeling and looking erection if it works for you and you're in that group that it works for, and it lasts anywhere between about 15 to 20 minutes to about 2 to 3 hours. None of that would be unusual. So sometimes that can be nice. You can turn around and have sex again like the old days when you were younger, because it doesn't necessarily go away when you climax in many men, because it's pharmacologically produced. But the bottom line is it's not for everybody. It has pros and cons, just like the vacuum pump, but some men find it to be something that helps them and really allows them to be sexual in ways that they're happier with, and that there's nothing wrong with that. The penile implant surgery is another thing. Nothing wrong with it either. As we move along, just so you know, from oral agents, which almost everybody will use and is a billion-dollar industry, to these more invasive things, less and less people use them. I will tell you the huge majority of men who oral pills do not work for will never use any of the treatments I'm talking about here past that. They won't use the vacuum pump, they won't use the injections, and this is probably even less people will use an elective surgery. There's nothing wrong with any of these things, but why would that be? Because some women on the other side, after menopause, remember, over 50% of women, and if it's not treated, eventually more, will have difficulty with vaginal atrophy, shrinkage, and dryness because of lack of estrogen. So sometimes having penetrative sex is not good on the receiving end either as women get older. So some women don't want to have intercourse or penetrative sex either. So you don't need any of these things to have intimacy, sex, and enjoy orgasms together. But if you want intercourse, you do need these things. The good thing about the surgery is it goes where you go. You don't have to travel with your medicine, your vacuum pump, your whatever. If you're out in the middle of wherever and could have sex without getting arrested, you could do it because this implant is inside of you. But this, again, is not for everybody because it's an elective surgery and has the same risks as any surgery. We know infection and malfunction and things are not typical. They're pretty unusual, so most people do okay. Now, if you live long enough, you're going to have to replace it because they usually last about 10 to 15 years. So you may have to replace it. But in general, those things are low risks. But the main complaints afterwards are pain. You're going to be sore. Think of it like a joint replacement, literally, replacing your knee or your hip. And what happens is, when you go to walk on your knee 2 months later, when you go to inflate your pump, it may be sore, it may hurt. When the weather's weird, it may be sore, it may hurt. The pain gets better and better, but right after surgery, it's a tender place to have surgery, and you're gonna be sore, and it's gonna take a while to totally get over the pain. So the number one complaint, of course, is pain. But it does get better, and most people get past that. The second most common complaint is shortening, because remember, this is what most of us would say, well, while you're in there, can you give me a big pump and make it a little bigger and longer and all that? I mean, who wouldn't opt for that option? That's just the truth from my perspective of most patients I've worked with. But they can't do that because they have to leave tissue there at the end because it will literally come through the end if they don't leave a tissue cushion, because there needs to be tissue between the implant and the outside of your body. So you do lose a little length. Even when you're fully inflated with this, you're not as fully inflated as you were in the old days when you had a full, good erection in terms of girth and length. But it's not a lot, but it is a little. Some people, again, notice it a lot. Some people don't notice it at all. But most people say shortening is a little bit of a second most common complaint. But lots of different things can happen because it's an elective surgery. So, bottom line is, what do I want you to go home knowing? First of all, you can have enjoyable intimacy, but sometimes conversations have to occur. And we don't talk about sex, do we? Usually the extent of our rhetoric is, yeah, so that's how we know. But outside the bedroom, it might help to have a conversation around, I love you, I want to be with you, I still desire you. And now, with my penis not responding how it should, even when I'm really excited, I still want to be with you, whether I'm hard or not. Let's work on intimacy. Let's work on time together and enjoying each other. I still want to be with you. You have to find your own words, but those conversations need to happen, and then intimacy and sex can both happen whether you're hard or not. If you want erections, we just talked about 5 different things. And guess what? There's tons of stuff out there that everybody wants your money, right? Everybody. And when it comes to erectile dysfunction, there's billboards along 94 and 90. Have you seen them? The Sun-Times, a full-page ad. Most of the time, remember, when they say they can make anybody hard, those are chop shops and they do injections. Well, I can make almost anybody hard too with an injection, but then will you continue to do it? And then some of them will charge you $1,400 for a vial that normally costs $100. So don't waste your money. Don't go in the gas station where most of the stuff is junk, and if it worked, it probably has a drug in it that it shouldn't have in it. I'm telling you about the things that are tried and true, have been researched, and they do work. I wish I had the magic wand. I would wave it over all of you today and say, yes, may you be happy and all of your sex lives and intimacy be wonderful. I would love to have it in my office. I would have a line around the world at the VA and at North Shore. And I would like nothing better. But we have to work with what we have, and this is what we've got. They all have good and bad. But can you still have a wonderful sex life? Yes. That couple in their 70s said to me, wow, I said, go home, work on it. We worked on all kinds of different things, and they chose the vacuum pump. We got it working. He practiced. He did everything. He was like a pro with it. I was like, that's awesome. She learned about her clitoris. He learned about getting erections with the vacuum pump. They learned about having sex without erections. They come back. He puts the pump on the table, sets it in front of me, says, "You can have that back, Dr. Alba." I'm like, "Okay, well, what do you want me to do with it?" He's like, "Give it to somebody else." I'm like, "We don't usually recycle those. Can you tell me what's going on here a little bit?" And he says, "Here's what," and I said, "And where's your wife?" He says, she said to tell you she's having the best sex of her life now that we both figured out what her clitoris is. And she said she's having orgasms like she'd never had before. And he said, he was one of those guys, and it's only about 5 to 10% who had more intense climax after surgery. Literally, he was one of them. And he said, "I'm having better climaxes than I've ever had in my life. We don't need that thing. We're not having intercourse. It's all good." And I'm like, "Okay." And he's like, "Is that okay?" I'm like, "Of course that's okay. If you're happy, I'm happy, definitely." And so I hope that some of this information will be helpful to you. We do have a book for each of you. The book I wrote because when I went around to groups across the United States, one in Oklahoma, they said, "We don't have somebody like you here. What do we do?" Somebody in Florida, one of my nurse colleagues said, "We don't have that, Dr. Alba. You need to write a book." So I wrote the book in 2012. Now I'm really proud that we put patient voices, partner voices in the book so you can hear. When you read about injections, you can hear the good, bad, and ugly of what people say about them, what people like, what they hate about them. So I'm really excited about the new edition. I make nothing off the book, by the way. I've never made anything off the book. The money goes back into the foundation. That's how we were able to create the second book. And if people want it, in the front you'll see they can go to my website, drjeffalbo.com, and download the original book, totally free. It doesn't have the quotes in there, but it's totally free, and eventually this book will be on there too. My only goal, there's no hidden agendas, is to get you the information you need to make informed choices about what you want to do in terms of these treatments. That's it. Period. There's no other agenda. So I'm happy to share the book with you. There'll be extras there even if you grab one. I'm going to leave them. Grab another one. All I ask is give it to somebody who needs this information, because it's my mission in life to get the book to men who need it. Because the ones who read it seem to like it, and I wanted to get it to the others who don't know anything about this stuff. So there's hope. Sex and intimacy can be amazing. It can be amazing. It may be different, but I've actually had people, and you'll read in the book, where they'll say, "It got deeper, it got better," because we had to pay attention to things we didn't pay attention to before. I think it can. I think it is possible. So there is great, great hope that you're a survivor. You know, I wear this bracelet. I got it because of prostate cancer awareness and the Sea Blue Walk. I almost dyed my hair blue. I didn't have the guts to do it like the other guy last year, my friend Todd. I almost did, and my wife's like, "You didn't do it. We got the dye and everything." I'm like, "I chickened out. I'm sorry." But I wear this to remind myself about how important prostate cancer awareness is, because it's the #1 non-skin cancer in men. But it was also designed for that, but one other reason, to remind me I am so blessed every day, because over 50% of the people in the world don't have clean water. And that was the other reason this was designed, to remind me every day, you got it so good it's not even funny. Even when your life is not good, it's better than a lot of people's lives. I hope you are able to embrace your life in that way too. I will take your questions as a group, and then afterwards I'll be here. So don't be shy. Come up. I will answer your questions. You know, I was out of town last weekend. I'm out of town next weekend for meetings. Dr. Helfand is an amazingly busy person. We're here because we care about you, and we've made it our mission in life to help people have better lives, quality of life. So I hope that you'll be brave enough to ask me a question, even though I know it's scary. And I know we had one from the internet, and I'm happy to answer that about the low-intensity extracorporeal ultrasound as well. But anyway, what questions do you have for me?
One second, I'll bring the microphone here.
Yeah, yes, I have a question
I'll get you next. Go ahead.
in regards to, are you familiar with rich plasma and stem cell therapy?
Absolutely. So he's asking about rich plasma, and this is another thing the chop shops will happily do for thousands and thousands of dollars with you. There's nothing wrong with it. It's something that's being researched as well as the stem cell research, and I will tell you that I do believe that that is the future of nerve regeneration, some of those things, especially the stem cell. There are 2 centers that are doing the human studies. It is entirely experimental at this time. It will not be covered by insurance, nor will the ultrasound. It is very expensive, but I do believe when they get it right, it is going to be a life-changing therapy, and hopefully it'll put me out of work and I won't have a sexual dysfunction clinic for men with prostate cancer anymore. And I would be thrilled if that happens. We'll all celebrate if that happens. But I do believe that's where we're headed. I'm going to pass these around so you can each take one as well. But I have heard of it, and I do think it's coming along. I do think it's not quite where it needs to be. And if you look at the double-blind research, you can see, yes, there is potential for both those therapies. Some of the therapies are aimed more at vasculogenic erectile dysfunction. And remember, most of the time, the reason you're not getting erections is because of the nerves back and forth. So if we fix your penis so it works right, and your penis has no idea it's supposed to get hard because it doesn't even know you're excited, we still have a problem. We'll pass some back, just pass them back, and everybody will get one. But the bottom line is, so a vasculogenic thing like ultrasound and some of the PRP, it's not going to help you, the plasma-rich it's not going to help you because you have a neurogenic problem primarily. Sometimes it can turn into a vasculogenic problem, but bottom line is I think you have to know what's wrong and why you're not getting erections. Especially if you had surgery or radiation, it's probably neurogenic, and you need something that's going to address that more so that your penis and brain are working together on you getting hard, because your penis knows you're excited, because it doesn't know you're excited when the nerves are traumatized and not working right. So they can do anything they want. Everybody up here got one? Just keep passing them around. You can come up. But you can, so you need to know that you're getting the right treatment for your problem. Can you hand them? All right, great. So anyway, so that's what I would say to that. I think there's great potential, especially for the stem cell in this particular case. I think there's a great, bright future, and I think it might happen in our lifetime, which is really exciting. But it's very much under research, and so you have to decide, are you willing to be one of those brave souls to be part of the new research for it? It has to be done really well, especially the PRP, and they have to have the right machine to do it right, but people will do it for you, and it does take a couple different treatments. The ultrasound usually can take 6 to 12 treatments, and again, when you look at the research on it, and it's specifically for vasculogenic blood flow, not so much for the problems you guys are having, you see that patients with blood flow problems, it can have a 2 or 3-fold improvement, especially in people with milder erectile dysfunction. So I do think there is a future, but right now it will not be covered by insurance. It's considered entirely experimental, but that doesn't mean they're wrong. I think there's some exciting things for the future, very different techniques to get at erectile dysfunction, and I'm always happy if we can find a new way to deal with it. Thank you for that excellent question. I hope I answered it well enough for you. I think he had one next, and then I'll get to the, yes.
There's a blood test that has your sex hormone in it. Does that have any effect with all of
So I'll repeat because he doesn't have the microphone. So he was saying there's a blood test. So there are blood tests to look at all your sex hormones. Testosterone is important, but there's other hormones that are important too. But remember, that has to do with hormonal. So if you're on androgen deprivation, those are important tests, but we know testosterone is going to be negated because you're taking it. You don't want to just know that, you want to see it on paper, because the goal of androgen deprivation is that it becomes down to nadir, and you want to make sure it is. But if you're not on that, remember, testosterone has a huge role in desire and the need for sex. It has a very small role with erections. It's not even considered a treatment for erectile dysfunction, although it can help with erectile dysfunction if you have a low testosterone and normalizing it. And remember, testosterone in the past is contraindicated. It has a contraindication on the prescribing information for men with prostate cancer. But if you've had your prostate cancer treatment and you don't have prostate cancer, that's a different case. But I will tell you, even if you have prostate cancer, that talk about old research, that research was based on a study of one case study, a second one came into it. long time ago that said we don't use testosterone in prostate cancer patients. But if you want to look at the work that supports it, Abe Morgenthaler from New England has done the work to show the saturation theory, and they do think it can be safe for some men to use testosterone, just like sometimes, and remember, if you have a testosterone-dependent cancer, there's lots of newer testing they can look at it closer, but it might be safe, but it's tricky and it's controversial if you have active prostate cancer, whether you should take testosterone or not. So you have to think about it a lot. It's sort of like a woman with breast cancer thinking about taking estrogen. It can be challenging, and so you have to be very careful and look at the research carefully and decide if it's right for you. So yes, we can look to answer your questions at your blood levels. We can look at all those tests, but the bottom line is that's not telling us a lot about erectile dysfunction so much. With erectile dysfunction, you can tell us, are you able to get hard enough? We know the answers to those questions. We can even do a color Doppler to look at things, but it's not going to change what we do for you. So sometimes we don't do that because we're going to spend a lot of money, whether your insurance pays for it or not, for something that's not going to change what we can do for you. Yes?
So you just brought up the issue of vascular leakage.
Uh-huh.
Does something like the injections work for that, or is that the men that fail?
Sometimes so does the injections work for people with more of a vasculogenic problem? So it can. Now it works great for neuro guys because it works directly on the penis and it doesn't care about communication between your brain and penis. That makes sense, right? That it would work great for somebody with problems from surgery with the nerves. But sometimes you can also have a vasculogenic problem. And then sometimes you will respond to the pill, but you could be a non-responder in the 15 to 30%. It depends on how bad the venous leak is. With a severe venous leak, it'll bring in the blood, but if it's severe arterial insufficiency or a venous leak, it may work, it may not work. In some men it does, because it has to be pretty bad for it not to work. In some men it will in the beginning, but as the vasculogenic problem progresses, it'll stop working over time. So I guess the answer is sometimes it does, sometimes it doesn't. So you just got to kind of see if it works for you. And if it stopped working, sometimes it's because the erectile dysfunction has progressed to where the venous leak or the vascular problem is significant enough that the injections no longer work for you. But I've had men on injections for decades and do well on it throughout. The vacuum pump too, because you're wearing a ring to trap it, that might help better because now you're wearing something to stop the venous leak from occurring, that ring at the base of your penis. So a vacuum therapy might be a better choice if you have a significant venous leak like that. That one might work better for you than the injections in particular. Did that answer your question?
Thank you.
Great. Okay.
You mentioned that you see men prior to them having treatment for prostate cancer.
Mm-hmm.
Can you speak just briefly about the value of that, both in terms of making a treatment decision and getting a jump start on rehabilitation?
So he's asking, I do see patients. So the surgeon you saw today, he makes sure every single patient sees me. And, you know, sometimes I'm like, they're not sexually active anymore. They don't have to see me. And he's like, I just want to make sure they're okay, Jeff. So I see all the patients before surgery. And the thing is we think the benefit is that you go in knowing information. To me, information is power, like you heard from some of the quotes. But I will tell you, I have a good friend who read my book and was upset by it because he's like, I don't want to know that, especially before I go into surgery. I found it, and someone on Amazon said they thought my book was depressing. I really tried to infuse it with hope, and that's the last thing I wanted to do. But I think often you don't have the information you need more often. And to me, I think about 80 to 90% of men want all this information. It is overwhelming because before surgery, I say to the patient, I know you're just thinking, I want to get through surgery, and you're not wanting to think that much about this. But I just want to introduce the ideas to you so you know what could happen. And the reason I think it's vitally important is some of the men in my study who were devastated by what happened, and they were sold short in what could happen. I had a guy, very young man, who when he was in my study was in his early 40s. So you can imagine how early he had the surgery. And everybody's like, you're going to do great, you're going to do great. And he didn't do great. Well, he was devastated. I mean, literally devastated. People are upset, people have become depressed, suicidal. This isn't everybody, but that's why I wrote the book, and that's why I like to see patients before they go to surgery, and I try to get the book into the hands of people before they go to surgery. But because I want you to know what can happen. And then if you do better, and people do better, hallelujah, I'm going to do the happy dance just like everybody else for you because I am so happy for you. But if you don't, and you had no idea what was going to happen, you think, what happened? They told me it would be fine. I thought I must be, that can be really devastating. So I think that's the value of it. Do you think it's a valuable thing? Oh, yeah. Okay.
Just to follow up on what you said, I found your slides so valuable. I had the radical prostatectomy at U of C in June of 17. And I was told that erection should come back in about 18 months. Well, it's 16 months now. And up until hearing you and seeing your slides, I thought, I'm running right up to the deadline, and then all hope is lost. And you gave
so it's
me
not
hope.
lost. But and remember too, when you're thinking about recovery, it's not like at 2 years, oh, there's my erection. It's a very slow, progressive thing. That's how it usually works. So you're looking for, wow, now I'm seeing a little more fullness, a little more, I'm seeing slight hardness. You're looking for a slow progression towards better. That is monumentally important. A slow progression towards better. It's so, so important. That's how it usually goes. It doesn't get better at 2 years or 18 months or 5 years. It gets better gradually, slowly, and it's little baby steps towards better, better, better. That's how you know you're getting better. And then now you start responding to the pills better or not. Some men never get, they're like, whether I take the pill or not, it doesn't make a difference. That's not most people, but they get better. And I say, if you're better without the pill, I'm even more thrilled. But sometimes you'll be like, now the pill's starting to do something. Oh, I stopped the pill after 6 months because nothing was happening with the pill, Dr. Albaugh. Well, what I'm telling you is, you respond differently as the nerve recovers at different junctures. So it's very, very important that you know and understand the process of healing. And yes, you can get better. And yes, there are things they can do to help you. So I'm so glad it was helpful because, this is exactly why I'm here today on my day off, is to talk to you guys about this stuff and help you with the information you want. So you kind of made my day. So I'm glad it was helpful to you.
Jeff, I infer from your comments about the ultrasound therapy that in post-prostatectomy ED issues, it's probably a waste of time then? Or?
Well, it's a lot of money. And so I'm not sure, I wouldn't say it's necessarily a waste of time, but what I would say is, remember, you're going after blood flow problems, which could be a problem from lack of nerve and not having erections for a while now. You could have vasculogenic too now. But the primary reason, if you had great erections the day before you had surgery and you don't afterwards, is neurogenic. And it's not going to get at that problem. That ultrasound gets at, what it does is it damages the cells, the vascular cells, so they can rejuvenate. It's like a rejuvenation therapy. Does that make sense to you? It's like when the cell's damaged, the body starts producing better and improved vasculature because of the damage that the low intensity ultrasound causes. We use high intensity to break up kidney stones, but for this we use low intensity to cause subtle damage and then hopefully rejuvenation of that vasculature. Does that make sense?
The practitioners do claim a neurogenic positive effect as a result.
Well, I'm just going with the science behind it. So the practitioners, I don't know what all they find, and maybe it will have that. I'm not saying they're wrong, but when I look at the science of what they're saying it does, and the studies, they were done very specifically in vasculogenic patients, not neurogenic patients. The studies for that, and I've got the meta-analysis actually on my computer, and you can look it up too and see, and you can, anyone can look at it, and it's got all the studies that were done and what they say about them. And they were done with vasculogenic patients, not neurogenic patients. So I just base what I say on the evidence and the science. But I'm not saying it's not possible. I'm just saying that's where we are so far.
Did you talk about the cost? Or?
So typically it can cost anywhere from for the whole process of it, I was hearing that it was costing somewhere between about $1,000 and $1,500 a treatment. And the treatment's usually done once or twice a week, and it's usually done for 3, 6, 12 weeks. It's going to cost thousands of dollars for sure. You need to see how much each treatment is and know that it's not going to help if you don't do the full course of treatments. And when you look at the studies, it was usually like 6 to 12 treatments minimum with it to be helpful. So you got to look at all that and decide for yourself. But you can get that meta-analysis study. I think it's from this year or last year, and it's got all the studies in there. It's got everything you need to look at and see to see how did they do it, how did it work, and all that. I know I'm standing a little bit between you and lunch, so I don't want to be too far, and I will stay through lunch for sure, but I'll answer another question. But I know you're hungry, and maybe you're sick of erections, so. All right.
Just real quick. So I think you covered this earlier, but I wasn't quite following it. So if you're taking Cialis, is there benefits? Is it taking just when you need it, or should you take it on like a daily or weekly basis?
Specifically, the studies for penile rehab showed that it didn't seem to make a difference whether you took it more on demand, and the on demand was maybe a couple times a week or once or twice a week or 3 times a week versus every day. But both of them were better than placebos. So to me, that tells me from that study that it still seems to work better than not doing anything, but it didn't seem to matter whether you did it a couple times a week with Cialis or whether you did it every single day. So I would say the jury's out on that. Again, I will answer your questions. If you didn't get a book, come get one. There's extras if you have a friend who wants a book. My goal is to get it to the people who need it. I will be around to answer your questions. You have a full 35 minutes for lunch, and it's right here. So I will stand here with you and talk to you about whatever, or sit here with you and talk to you about whatever you want. I'm yours till I leave right after lunch to go home and be with my wife a little bit today. Okay? So thank you so much.
Thank you so much. Yeah. This is great stuff. Excuse me.
Wonderful.
Awesome information. Thank you, Dr. Alba. Before we go to lunch, we just want to take a few minutes to recognize our sponsors, do a quick introduction, and that way you know a little bit about the folks and the information that are on the tables in the back, if you're interested in stopping by and talking with everybody. So if our sponsor representatives are interested in coming up, or I can go to you. But we have Ellen Ivey with Janssen, Sue Hensley with Pfizer, Rick Tazioli with Sanofi, Andy Del Greco with AbbVie, and Julie Houghton with Amgen. So I'll just pass. Again, this microphone is more for our webcast viewers than the in-person audience. So please speak loudly, and thanks so much.
Chuck, thank you. Rick with Sanofi Genzyme. We've had the pleasure of working closely with us two pretty much ever since us two started. And as you remember, Dr. Halprin, earlier in the day, he mentioned it's so important to become educated and learn as much as you can about prostate cancer. Us two does a wonderful job educating and working closely together. So it's really been a great deal of pride to partner with us two on this initiative. So that's really our goal as well, to help educate patients. We are the company that has 2 chemotherapies for prostate cancer. So if you have advanced prostate cancer, you'll notice in your bag that there's a handout, a brochure, Understanding Chemotherapy Better. The chemotherapy of today is not the same as it was 15 years ago. So there's been a lot of advancements and a lot of changes. So if you read that brochure, hopefully you understand it better. But it's really a pleasure to partner with us too, to help. We know it's a difficult journey as patients go through, and we're here to help as us two is as well. I'll pass the microphone.
Thank you. Hi, everyone. Ellen Ivey from Janssen Oncology. And much like my counterpart here on the industry side, we also really appreciate all these educational events and being able to support them with the partnership through us too. We have also been a great partner of theirs for many, many years, and really value the work that they do with the patients and the caregivers. We also agree very strongly that it's very important for shared decision-making and to empower the patient and the caregiver to make the right decisions for themselves, because everyone's an individual. Even though our bodies work similarly, we all have individual needs. So we very much stand behind that and really value the opportunity to sponsor these events, and are glad to be here with you this afternoon and morning to participate. Unfortunately, we had a FedEx problem, and our materials are somewhere between New Jersey, Pennsylvania, and Chicago. So my partner is here, and we're happy to talk about our two products. We have Zytiga as well as Erlita. So a product in the advanced space as well as now the early space. So we're happy to answer any questions you have, even though our materials aren't here. And thank you all for being here with us this morning and afternoon.
Hi, my name is Sue Hensley. I'm here representing Pfizer Oncology and Astellas, and on behalf of our two organizations, we are also very pleased to be able to partner with us too, and really appreciate the work that they do to support patients when confronted with a prostate cancer diagnosis, as well as helping support them throughout their journey. So thank you all for being here today. Thanks to the physicians for being here, and to Chuck, Terry, and Tim and their board members who are here as well. Again, echoing the comments, really, they do great work nationally and internationally, and we're proud to be a sponsor. We do have a couple resources at our table. One is a terrific book on nutrition that we partnered with the American Cancer Society. Please come over and grab one of these. And my colleague, Kadi, is going to talk a little bit for a minute here about a resource that Pfizer Oncology offers to all patients living with cancer.
Thank you, Sue. My name's Kadi Petridis, and as Sue mentioned, I'm with Pfizer as well. And, what a great event, to have patients come out and to hear and discuss topics that you don't always get a chance to discuss with your physicians, especially topics like sexual health. Pfizer's really trying to do a lot more to really elevate the patient experience when patients are dealing with cancer. And so one of the things that we created a little over a year ago is this Living with Cancer app. And it's free. You can download it from, the iTunes store or Google Play. And it's really meant to, help a patient be able to keep all their information in one place related to their care. So you can keep a calendar of your appointments. It reminds me of like a mini Facebook page where you invite just a select few people to join. And if you have a request for a ride to an appointment, someone to pick up a prescription for you, can enter it right on that app. And, whoever accepts that, then it basically takes it off the queue. But there are other things you can do, like tracking your mood, looking up information on, events in your local area. So really a nice, kind of one-stop shop, and even keep records of questions that you have for your physicians and things of that nature. So feel free to stop by. We do have the brochures here that give you more information on that. And then as well, talk to Julie, who's our rep for, Xtandi, which is our product in M0, castrate-resistant prostate cancer, and also metastatic castrate-resistant prostate cancer.
Oh, sorry. Hello, Andy Del Greco with AbbVie. It's an absolute pleasure to be here with you today. We've had a presence our products had a presence in the prostate cancer world for decades now, really. So we've been there for almost since day one of the initial therapies for prostate cancer. So you should all applaud yourselves on your quest for knowledge. We're absolutely ecstatic to be part of this journey for yourselves, and you should all be very proud of yourselves. Thank you very much.
I just wanted to say real quickly that the book was created, I think my
Okay, still on? Okay.
From the generosity of Bill and Pam Ross, who put their name on the sexual health clinic, which is a very brave thing to do. And so, and then also from a lot of other generous people who donate to the foundation at North Shore. And that's how we're able to bring you all those things for free, which is great. So I have to really, I'd be remiss. All the research I do, everything I do is funded through the foundation at North Shore. And it's because of very generous people who have given money so that we can give you the exact things we do. And I'm on the S2 board as well, and we're just excited that you're here. Thank you so much for spending your Saturday with us. It's a wonderful thing to have you all here. Are they ready for lunch?
I think any other sponsors that we get everybody? Okay, all right. Okay, hello, welcome back again to the Pathways event for prostate cancer. So everyone here at the event has got their boxed lunches. Hopefully everyone on the webcast had a chance to take a break, and we're ready to kick off our afternoon session. So we're very excited to address another very important topic with prostate cancer side effect management, urinary incontinence, and we're very pleased to have Dr. Heather Moki-Cordova here with us. And she's been the pelvic floor health physical therapy coordinator at University of Illinois Hospital, UI Health, and adjunct faculty at UIC since 2011. She's an international lecturer and has been on various research, educational, and director boards for local, national, and international nonprofit organizations to increase awareness, education, treatment, and resources for practitioners and patients in pelvic health. So please join me in welcoming Dr. Heather Moki-Cordova.
Thank you. Thank you. Good afternoon. Thank you so much for having me here today. It's really an honor and a privilege to try and bring some information to you all, and I'm honored to be part of the Pathways program. I've been a physical therapist for over 16 years now, and I feel very blessed that I really feel that I do a job that I love to do, and I love interacting with patients and trying to make differences in the lives of my patients. I'm here today for you, so we will do some education, and I have a presentation. At one point, we'll do some exercise, and I'll definitely save some time at the end to answer your questions because I am here for you today. So thank you once again for having me. Today, some of the objectives are to understand what a pelvic health physical therapist is, and what I do, also to identify the anatomy of the male pelvis and to understand how it affects prostate cancer patients. We want to learn some exercises that you can start doing today, as well as just identify pelvic health resources for you that maybe you may need or not need, but just know that they're out there to support you in your journey. So what is a pelvic floor therapist, and how did pelvic health PT come about? So I am a physical therapist. I went to graduate school and I received my master's. I became licensed by the state of Illinois, and I have worked. Since that time, once I was licensed, I started taking continuing education and became a specialist in pelvic health. Now that's just like a doctor who goes to medical school and then goes on to do a rotation or specialize in a certain area, like urogynecology or urology or something like that. So I am a specialist in physical therapy. So through the American Physical Therapy Association, there's many different sections of it. There's the Women's Health / Pelvic Health section. And how did this all come about? So back in 1977, there was a woman named Elizabeth Noble, and she decided that women really went through a lot with childbirth, before, during, and after, and that a lot happened to their pelvis, and that we needed physical therapists to pay attention to this. So they formed a section through the American Physical Therapy Association called the Obstetrics and Gynecology section. So we started there, and we kept progressing, and the scope continued to increase. Then in 1995, they said, well, the section of obstetrics and gynecology is outdated because we do so much more. And so in 1995, they turned it to be the section of women's health. So since I've been in physical therapy, I've had a hard time saying I'm a women's health specialist, because men don't want to go see a women's health specialist. They want to see a pelvic health specialist. In 2011, actually, when I was on the board of directors for the section on women's health, we made some updates, and we changed our mission and vision statement to include to represent all the patients and the physical therapists who supported men's health and pelvic pain and fibromyalgia. So we just continue to widen our scope. Name changes are always hard, but just recently in 2017 and 2018, the section of women's health changed their name to the Academy of Pelvic Health Physical Therapy, which is much more encompassing. So our scope has continued to widen to make sure we support men, women, and children and any type of pelvic health issues. And you can see there's a list from incontinence and pelvic pain. We work with pelvic pain, rectal pain, vaginal pain. Lots of fun things I do every day, right? We work with rehab following breast surgery and prostate surgery and other gynecological surgeries. And we really want to work on wellness and prevention where we can. So to understand a lot about what's going on with your body with prostate cancer, it's really important to understand the anatomy in the body. So we're going to start out with literally the bones of it. And this is the pelvis. And so when we look at the pelvis here, we have 3 bones. You have an innominate, and here is your sacrum. Then we'll go on, and here's a cross-sectional view, just looking here. Oops, excuse me. We can see here the belly, here is the butt. Right here is the symphysis pubis. That is that bone that you can feel right here on your pelvis. Right behind that bone, we have the bladder. This is a picture of a female. So then we have the uterus, we have the rectal canal. You can see how everything fits in very tight in there. Now we have the male. Once again, here's your belly. Here's that bone, the symphysis pubis, or the pubic bone. Right behind that, we have that beautiful bladder. From the bladder, you have a tube that comes down through the penis called the urethra. Right below that bladder, you have your prostate. Behind the prostate, we have the rectum. Down here, we can see the end of your spinal column coming down. I'm going to continue on. The prostate is usually about the size of a walnut or a chestnut and weighs about 30 grams. And it's part of the male reproductive system. It produces a fluid that makes up semen, but needs the sperm cells from the testicles and fluids from other glands to be effective. And also, the prostate helps expel semen during ejaculation. So here, these are the pelvic floor muscles. There's lots of beautiful names that go with them, and I don't expect you to remember the names, but just know they are very important. We can see here you have your ischiocavernosus, you have bulval cavernosus. Here we'll say that you have a triangle of muscles, and this is your superficial layer. Then we also have a deep layer coming down here, and this is the levator ani. Now, today I talk mostly about incontinence, but I also work a lot with erectile dysfunction, and these muscles go hand in hand in both incontinence and erectile dysfunction. Both the ischiocavernosus and the bulval cavernosus helps the penis with maintain erection. The bulval cavernosus here encompasses 33 to 50% around the base of the penis, and it helps to keep the blood in the penis when it wants to stay erect by putting pressure on one of the veins. So if those muscles are weak or not working, they're not going to be able to do their job very well, and that will cause problems with having the rigidity in the penis during erection. So once again, we have the pelvic floor muscles, we have the superficial layer, wonderful names, ischiocavernosus, bulbal spongiosus, and the superficial transverse perineal. Now, depending what anatomy book you look in, there can be considered 2 layers of pelvic floor muscles, but there can also be considered 3 layers of pelvic floor muscles. If you're reading a book that has 3 layers, they usually refer to a deep transverse perineal layer, which accounts for the 2nd layer. Okay? But mostly you're going to see there's 2, the superficial and the deep. And here we have the deep layer called the pubococcygeus, ischiococcygeus, and puborectalis. Once again, you don't have to remember these names, but they're important. So once again, we see those nice pelvic floor muscles, we see the top superficial layer, and we also see the deep layer. And what are the functions of the pelvic floor? Basically, there are 4 functions of the pelvic floor to simplify it. There's a lot more, but one, there's a supportive. It keeps all the organs in, and it helps to provide support and tone for both the vaginal and rectal walls. We're missing rectal on the slide, I apologize. There's also a sphincteric. Sphincteric acts as a closure. So like we just talked about, the muscles in that superficial layer will act as a closure to keep blood in the penis when we want to help keep it erect. Also, sphincteric, it's going to act as a closure so that we keep our urine and feces inside our body until we're ready to let them out. A very important function. There's a sexual function that helps with the contraction of the pelvic floor muscles during intercourse, increases pleasure and tone in the vaginal and rectal canal. And last but not least, it's stabilization. When we think everybody hears how important your core muscles are, your pelvic floor is the floor of your core. So it's your foundation. So, and how important is the foundation of your house? Very important. Continuing on, we see, as I mentioned, your pelvic floor muscles are your foundation, the floor of the core. They help with continence. They help with sexual function. They also, believe it or not, help with posture because we need inter-abdominal pressure to help maintain the spine. And so when we have that pressure, the pelvic floor muscles make sure we remain continent so we're not walking around leaking all day long. Pelvic floor muscles also help with respiration and speech. So these small muscles down around our genitalia are very, very important. Innervation, I would be amiss if I didn't at least acknowledge the innervation of it. It's by the sacral nerves S2, 3, and 4. In school or in classes, they tell you S2, 3, and 4 help keep pee and poo off the floor. Very important, okay? So we also have, from that nerve, and we'll see a picture in a second, there's 3 branches of it too. There'll be as we come here, we can see the pudendal nerve here as it's coming down, and we'll see 3 branches, a dorsal nerve to the penis, and then we have the deep perineal nerve, and then we have inferior anal nerve in the back. So another picture that I like to show that's really important is as we look at the nerves here, and we see you come from your lumbosacral plexus. Now I know none of you, well maybe some of you may be anatomy majors, and this is too much, but just stick with me as we get there. Coming down from the nerve plexus, we have the pudendal, but then you have this pelvic plexus that comes here, all these nerves that are coming down here. And as you can see, they're on the posterior side of the bladder. And of course, they're on the posterior side of the prostate as well. So for some of you, when we're talking about a nerve-sparing technique or not a nerve-sparing technique, this has a lot to do with it because it depends where the cancer is and if they're able to dissect out or around. And there's other factors that go into it too. But I just think this is a beautiful picture to help us appreciate the complexity of the area. Then this isn't the best picture, but what I want to show you here is here you have the bladder. Here you have the prostate, and down here we talk about an anal sphincter. So you have an external anal sphincter. That's going to help with closure as well. So sometimes during that prostate surgery, all these things are so close together, things can get damaged, and sometimes they have to remove more based on what the needs to remove the cancer are. So pelvic floor is also very important for muscle stability. When we think about those little muscles, they work in conjunction with your diaphragm, which helps you breathe. You also have your transverse abdominal muscles, which are in your stomach. And they work in conjunction with the stomach and the back and the spine, all along with the pelvic floor. So things really work together. So when one area is weak, it can affect other areas and cause more problems too. The diaphragm, when we talk about like the top, the roof here, and the pelvic floor muscles work together with breathing. And also, the pelvic floor muscles, when they contract, there'll be a little co-contraction both in your abdominal muscles and some of your spine muscles called the multifidus. So think about how surgery and treatment can affect the body and the muscles around it. So here we can think about a robotic approach or a laparoscopic approach, which is the least invasive route, but still you're going through the abdominal wall and trying to get to all those small areas. A little more involved than a lot of people have thought. So when we think of the effects of the prostatectomy, we want to look at what was the surgical approach. Some people have the option of having robotic surgery. Other people, they've gone and they'll have a suprapubic approach where they have to go in the lower abdominal area. Some people even may have had a perineal approach underneath the penis area. So that can really affect about, my father-in-law actually had his prostate removed, and he had a very thick pubic bone. And so that caused some complications and just took the surgery longer just to get around that bone. There's also the removal of the prostate. Was it easy to come out? Is it all contained? That's what you're hoping for. There can be loss of smooth muscle. When we talk about smooth muscle, that's a potential for loss of support for continence. That can lead to incontinence or leakage. We talk about potential damage to the sphincter, which I pointed out, another way that's going to keep things in and hold it closed. Also, the possible loss of the full sphincter muscle, and also damage. Even when you have a nerve-sparing technique, there still can be damage or irritation or bruising to nerves. And I have always said to a lot of my patients, whether I'm working with them for whatever, there's one thing in life we don't want to do. We don't want to upset a nerve. They're very fickle. You don't want to piss off a nerve because they can cause problems. The good thing about nerves is that they will slowly heal, but it takes a long time for nerves to heal. They heal very, very slowly. So I like to tell people, I want you to think of your body as a house. So our front door is our abdominal muscles, our back door are our back muscles, the roof is the diaphragm, and your foundation is your pelvic floor muscles. So how important is the foundation? And so obviously this house does not have a very good foundation. And so a house without a good foundation can kind of fall over. And we think about the house that we live in when we go through surgery, when we go through different illnesses, we can feel like we're falling over, and we need to figure out how to get back straight and tall and have a good foundation. So what other muscles are relevant in pelvic health? Now, if you Google how many muscles attach in the pelvis, there has been answers anywhere from like 33 up to 48, I believe. So a lot of different muscles will attach and insert in and around the pelvis and the fascia. And even if we look at the other muscles like the hamstring muscles, we want to look at the flexibility about the muscles and also your joint range of motions, depending on what your prior health is. When people have really, really tight hamstring muscles, and those are the muscles on the back of your thigh here, if they're really tight, they can pull you back. They can change the positioning of your pelvis. They can affect your ability for walking or stretching. So we also look, when somebody comes in for physical therapy, we look at a lot of the muscles that attach in and around the pelvis, from the hamstrings to your hip flexor muscles, the muscles that make your legs go in and out. We look at abdominals and a variety of other things. So when we look at the research that's coming out, they're showing more and more, as I mentioned, that these pelvic floor muscles are related to other things. So like increased incidence is noted in people with low back pain when they have pelvic floor muscle dysfunction. There's an increase in low back pain if you have pelvic floor dysfunction. There's also an increase in the severity of your low back pain that research has shown at Kim et al. In 2010 that is associated with your increase in severity of urinary incontinence. And the pelvic floor muscle dysfunction has a stronger association with low back pain than obesity or the level of physical activity. So these really are really important muscles. And I know all these things don't necessarily pertain to you, but it's just to highlight that these small muscles have a very powerful impact in our body. Other anatomy, just to be noted, and when somebody comes in or we're looking, did you have pre-existing back pain or spinal problems before any of these other health problems? We like to look at the viscera or the organs that are air. We look at ligaments holding the organs in place, the fascia in the body. When you have surgery, fascia is cut, tendon insertions in and around the pelvis, and of course your blood and lymph supply, and I noted nerves earlier. So that's enough of anatomy, and I've probably already bored you already, but hopefully we have a couple good takeaway points from it. So when we talk about incontinence, what are we talking about here? So how many people are we talking about suffering from incontinence? If we include everybody in the United States. 25 times the amount of people who died in the Vietnam War. We're also talking, for me, I would have to see 25 patients a day for 2,739 years to try and treat everybody that has incontinence through the United States. So we're talking over 25 million Americans suffer from some form of incontinence. Now, the prevalence of urinary incontinence in men is a little different, and I'll explain some of it here now. Prevalent depends on how incontinence is defined. Some people, first of all, nobody wants to talk about leaking urine. It's not a popular subject, but if you want to, I'm one who always talks about it. And it varies because some people will say they won't count their dripping. Some people will say incontinence is more of just a loss, but the truth is that incontinence is any unwanted loss of urine or feces is incontinence. But it varies and is age-related, and we can see research is showing that up to 39% of men have urinary incontinence, and it increases with age. Also, if you start looking at the research out there of what is the prevalence of incontinence post-prostatectomy, it varies a lot. I've seen some areas where they say it's only 20-some%, and I've seen up to 90%. But mostly, two resources here show that 66% of men experience urinary incontinence after prostate cancer, and another one said up to 60%. So numbers in post-prostatectomy urinary incontinence are getting better, and that's due because they have better surgical techniques, as well as there's more medical advances to use. So to understand incontinence, we also want to understand what is a normal bladder pattern. So how often should a patient go in a 24-hour period or during the day when you're awake? During the day when you're awake, you want to go about 5 to 7 times a day, and it is normal to go anywhere from every 2 hours to every 4 to 5 hours from what Larson et al. Showed in 1992. How many times at night? 0 to 1 is normal. There's some research that says up to 2 times is normal, but me and the person I am, I will not agree with that because I say we're allowing ourselves to get lazy, okay? And how much should you go? In the morning, your first void in the morning when you get out of bed should be your largest, and that can be anywhere from 8 to 12 ounces. And during the day, when you void, it should be anywhere from 6 to 10 ounces. Now the question is how do we know how many ounces are we really peeing? That's a hard question, right? So a lot of times I tell my patients that whether you sit down or whether you stand, when you start going, you can count 1 1,000, 2 1,000, 3 1,000, and when you go, we should at least urinate for about 6 1,000s or 6 Mississippis. Okay, some people don't like to talk about rivers because then it makes them have to go again. Okay, so incontinence is the involuntary loss of urine or feces, and there's lots of different types of incontinence. And I have to tell you, I could turn this into a 2-day presentation if you want to stay overnight tonight, right? So we're going over some things briefly. So stress urinary incontinence is a bladder storage problem due to an increase in intra-abdominal pressure. So that means you're leaking with coughing, laughing, lifting, sneezing. We bend over to lift up something heavy, we go, and as we hold our breath, that increases the intra-abdominal pressure. When we cough, that increases intra-abdominal pressure, putting more pressure on our bladder and those pelvic floor muscles that may be weak. Then there's also urgency incontinence, and that's the gotta go, gotta go, gotta go, go, go. It's a bladder filling problem due to uninhibited involuntary bladder contractions. This is where we see people who have frequency and urgency. That's when a patient might ask somebody, how long can you delay the need to urinate? And they'll say, I can't at all. And that's not normal either. your bladder turns something into it that going to the bathroom becomes a 911 call, and this is not a 911 call. Also, it's when people are getting up multiple times a night, more than that 0 to 1 time, or you just went to the bathroom, you sat down to go back to read the paper or work on the computer or whatever, and you feel like you got to go 10 minutes later. That's not normal. Now, in all fairness, we have to remember that input is going to get output as well. I met a woman last week who was telling me she was drinking a gallon of water a day and was telling me that she had a bunch of increase in frequency. And I said, well, you've just doubled your water intake, so you are going to be doubling the amount of times you go to the bathroom. Do we know how much water we should be drinking a day? Should be, typically they will say 8 glasses of 8 ounces or 64 ounces a day is what is recommended overall. This is also, the urge incontinence is, they'll have different triggers. So people will come into my office and I'll say, if I turn the water on, does that make you want to go to the bathroom? How many people experience that when you put your key in the door? When you're coming home, that you feel like you have to go to the bathroom. That's another trigger. Sometimes when people in the summer walk into a store that has really cold air conditioning, that's going to make them going from cold to hot or hot to cold as well. All those symptoms usually are associated with urgency incontinence. So, and then we have mixed incontinence, which is the combination of stress and urgency put together. So you're lucky enough to have both the leakage with the coughing, laughing, lifting, and sneezing, as well as the urgency and the frequency, urgency, getting up multiple times at night. There's also transient incontinence, because sometimes when we're leaking or if we have increased frequency, like if certain people have to take medication for their heart, they have a water pill, and in the morning when they take their water pill, they're going to have to go to the bathroom multiple times. But that medication is basically trying to pull some of the water out of your body, so you're urinating out. So that explains it. So that's a transient incontinence because of the frequency. But there's also sometimes infection, different medications, restricted mobility. There's a variety of others. And if you look here, it looks at diapers, DIAPPERS. Somebody made that up a long time ago. So pelvic floor muscle strengthening, we can look at a lot of different research, and there's good research and there's bad research. And this was a pretty solid study here back in 2000 showing that pelvic floor muscle strengthening is recommended as a first-line treatment. So when we look at conservative management post-prostatectomy urinary incontinence, Bauer et al. Showed that pelvic floor muscle training is once again recommended as the initial treatment for stress urinary incontinence. Now also, there are no random controlled trials in research that compare non-invasive approaches to invasive treatment. So there's also there's an antimuscarinic therapy, so a medication that you can take if you're having the urgency that can go along with working with pelvic floor therapy too if you have excessive urge. And that's something for your doctor to decide what is appropriate for you as well. If we look at a systematic review in 2006, they said based on the available evidence, pelvic floor muscle training with or without biofeedback will increase the return of continence more than no pelvic floor muscle training in men with urinary incontinence after a radical prostatectomy. So I'll explain a little bit more about biofeedback as we talk about treatments, but once again, we can take medication, there's surgery, there's a lot of different options, but learning to make your body stronger is the first line of treatment. So there's a variety of other male issues here that we can talk about. Here in post-prostatectomy, there was another study that showed up to 90% of patients will have some form of urinary incontinence after post-prostatectomy. There's pelvic pain that affects 8 to 10% of men in general. So sometimes it is common after prostatectomy to have some soreness or a little pulling or aching in the penis or in the pelvis. That's normal and that should go away. If it doesn't go away, that's something to talk with your doctor about. there's erectile dysfunction that in general will affect between 15 to 30 million men. Now, when I give those numbers, 15 to 30, it's because I look at various resources and they do vary. I mean, not a lot of people want to say, hey, I pee my pants and I'm having sexual problems. They don't always want to admit that, but this is a safe space to do so, and with your doctor. There's also other problems men deal with, which are very common, like BPH. I'm sure many of you are aware of that. The benign prostate hyperplasia. As we get older, that prostate gets bigger, and that's another reason why it's really important to go to your doctor and get your normal checkups to make sure it's just BPH and not prostate cancer. There's also another problem called prostatitis, which is inflammation of the prostate, and that's a whole nother can of worms that we're not going to touch on today. So erectile dysfunction, what can you do? There's a variety of different treatments out there, and I believe Jeff spoke to you guys about some of those earlier. But also, your doctor will decide with you what is the best approach. There's medication, there's physical therapy, there's different types of pumps, there's injections, there's a variety of things you can do. But what does the research say? And there's actually a research out by Dory et al. In 2005 that looks at the effects of pelvic floor muscle strengthening in men with erectile dysfunction. There were two groups, one that did the pelvic floor muscle training and one that just did lifestyle changes. In the group that had pelvic floor muscle training, they actually, within 3 months, there was an improvement overall, and in 6 months, 40% of the men returned to normal function, and 35% reported that they were greatly improved just by doing some exercises. So there's lots of options out there. In a medical documentation summary, I'm going to read this to you here because I want you to think about it. 54-year-old man who presents to physical therapy with urinary frequency, urgency, and leakage. Patient reports being able to delay the urge to urinate for about 2 minutes and getting up to go to the bathroom 4 to 5 times a night. Patient also reports about 10 small daily leakage episodes on the way to the bathroom and 2 to 3 larger episodes per week that wet his pants or whatever he's wearing. Patient reports needing to go to the bathroom 2 to 3 times per hour, as well as he's scared to go out due to his urinary incontinence. Patient reports this issue for the past 5 years, but it has also gotten worse in 6 months. What does this tell you about this patient? Yeah, lots of problems. So, but we can start by saying, first of all, he can't delay for 2 minutes. So he's going to be scared to go to the grocery store because if he's in line to check out and he's got to go to the bathroom, he's going to have to stop what he's doing and run, and he can't go grocery shopping, a basic, simple thing that everybody pretty much needs to do. He's getting up 4 to 5 times a night. That means there's very poor quality of sleep. Is he having problems getting back to sleep once he gets up to go to the bathroom? There's a ton of leakage going on. He's going to the bathroom every 2 to 3 times an hour. So if I asked him to go to a movie with me, he would probably say no, because he'd say I'd have to go to the bathroom probably 6 times during the movie, and that's not fun. Also, he's scared to go out, so there's social isolation. There's loss of self-esteem. So the quality of life is more important than life itself, came from a quote from Alex Krell. But also, we have to think about quality of life in these situations because a lot of people with incontinence suffer in silence, and we don't need to because there is help out there. There are people, when you get up 3 to 10 times a night to go to the bathroom, people who are trying to work and get in trouble for taking too many bathroom breaks, also avoiding social outings or intimacy due to urinary leakage, or people who are just in general embarrassed to talk about it and ask for help. So these are real problems. And the patient reality is sleep deprivation, social isolation, getting in trouble at work, loss of job, loss of self-esteem, loss of sexuality, loss of income, many other things. So there's many common approaches from a physical therapy perspective for incontinence and ED. We're going to talk about mostly behavioral modifications today. So Behavioral modification, so things we can change. Usually I will start by looking at a bladder diary to see what we're eating. We do dietary education, and there's simple things we all can take home today. Looking at fluid management, fiber education, because even though we're talking about urinary incontinence, a lot of people stop drinking and then they get constipated. And if you remember those anatomy pictures, if we get all this feces and poop stuck up, it's going to push onto the bladder and cause more leakage anyways. So it's not a win-win situation there at all by limiting your fluids. We also have different bladder irritants. We can talk about voiding mechanisms. We can also talk about time toileting or different protocols. So here's an example of a bowel and bladder diary. And just simply, I can show you, when you look at what is the intake of liquid, there's coffee, there's tea, there's coffee, there's Diet Coke. Caffeine is a bladder irritant. Now, I'm not telling you can't drink caffeine, but we want to do it in moderation and make sure we get some water into our diet. Here, bagel with cream cheese the patient's eating, and a hamburger and french fries. Where's our good fiber in there? This patient's probably going to be getting constipated. We can see his bladder, there's multiple times going to the bathroom in the day, and at least twice an hour. So this also tells us there's frequency. We see there's a variety, and so here is where the patient thought they had to go to the bathroom and have a bowel movement, but wasn't able to, so is constipated. So input will make output, so it's important to know simple things we can do to change that. We see here coughing and sneezing. We know they have stress urinary incontinence, as well as they're going to the bathroom and leaking on the way going to the bathroom. There's urgency, and we see the frequency noted here. Bladder irritants are coffee, caffeine, alcohol, citrus, spicy foods, artificial sweeteners, and others. Now, once again, I'm not saying you can't have any of these, but don't go and have, coffee for breakfast, have a big Italian lunch with red wine for lunch and Mexican for dinner, because then we're getting our spicy, our citrus, we're getting our alcohol, we're getting our caffeine all day long. So limit and make sure we're getting some water in as well. We talk about behavioral training and different voiding mechanisms, whether there's a sitting posture or a standing posture as well. We talk about breathing. A lot of times if we have to go, people as they're running to the bathroom, they hold their breath, then that increases the intra-abdominal pressure and actually causes more leakage in some patients. We also want to talk about learning to relax the pelvic floor. Many men tell me they're standing there and they're very stressed out and they're trying to pee and it doesn't come out. And as they're getting stressed out, they're tightening their muscles instead of relaxing. Sometimes people who are going multiple times, we put them on a time toileting where we figure out how often they go, and then we slowly increase it incrementally so that they can have farther spans between urination. Behavioral modifications, there's the urge protocol in the NAC, and breathing. We want to make sure we're not holding our breath. If you are constipated, when you're breathing, we don't want to be pushing. You want to do pursed lip breathing so that you allow some air out of your mouth instead of pushing, because that's going to put more pressure on the pelvic floor. And to avoid Valsalva, that's when we hold our breath and we're pushing down. So behavioral training. When we talk about the bladder, after we've gone through a lot of these surgeries or problems or healthcare problems, we find that our bladder becomes a bratty 2-year-old. So what are we going to do? You need to teach it manners, and how do you do that? You be consistent. If you're trying to work on changing, you do it a little bit every day, and you got to be strict with yourself. So the urge protocol, to learn to delay the urge to urinate, I tell people to contract the pelvic floor muscles 5 times quickly, and that sends a message. Research has shown that will send a message to the bladder and help it relax. But then, because we are thinking about peeing, our brain's going, you got to go pee, you got to go pee, so you can't think about it. So we have to do something for our brain to distract. So I recommend counting backwards from 100 by 3s. Think about all your family members' birthdays. You can think of a recipe, but you want to do something that's really going to distract you. In addition, when the pelvic floor muscle contracts, there's a short-term reflex inhibition of the detrusor or the bladder muscle. And that was shown at Park et al. In 1997. So I tell people with this, people are like, well, so you're telling me it's all in your head? And I said, no, but when we get anxious, it makes our problems even worse. So it's not only mind over matter, but it's your brain over bladder and telling your bladder and teaching it to hold properly. Another thing we talked about, or that we do in behavioral training, is called the knack. The knack is to squeeze before you sneeze. So you want to perform a pelvic floor muscle contraction in functional situations, and you can squeeze before you cough, laugh, sneeze, or lift. Now, it won't always work because sometimes we get a sneeze out of the blue and we can't catch it, but that you're starting to recruit those muscles to activate to add is a little bit more of a barrier so that you don't leak as much urine, and eventually, hopefully, you will leak no urine at all. And Miller et al. In 1998 demonstrated a decrease over 80% in urinary leakage with 3 consecutive contractions. So breathing, we talked about the pursed lipped breathing just a minute ago instead of pushing down. And also, a lot of times around these we get very anxious, and it's really important when you're going through surgery, after surgery, just to do some good diaphragmatic breathing. That helps to calm the whole system. It promotes relaxation. That's where you breathe in through your nose and out through your mouth. You bring the air down into your belly, called belly breathing. There's also a lot of apps this day and age that you can get on your phone that can teach you all to breathe. So we also talk about pelvic floor isolation, pelvic floor muscle isolation. And that is really going to be part of the mainstay of pelvic stability. But when we look at it, we have to look at the ability to both shorten the muscle or contract it, and the ability to relax the muscle and lengthen it. We want to make sure what is the quality of the contraction, and we want to, does the patient know what they're doing? Do you know how to do that? And we're going to talk about this after we have a little break. But there's different cues that have been told in research for years, and some of those cues we found out aren't the most effective, and now we have better ones as we've done more research. Is a patient able to relax their pelvic floor muscle, or do people walk around trying to keep everything tight so they don't leak? And then by trying to keep everything tight all the time, that can cause some muscle dysfunction as well. So in general, we talk about to slowly squeeze the pelvic floor muscles in for a certain amount of seconds, to relax fully. We have them repeated so many times per day, but there's other exercises we can do too. So there's different, this is the real-time ultrasound here, and this helps us look at the bladder and we see the muscles around it. And it's been shown as a great way to look at male pelvic floor contractions. Biofeedback is another way that you can have an internal sensor, or you can have little stickers that are put around your perineum or around your anus that'll look at the muscle activity, and we use that to help teach people how to contract their pelvic floor muscles. So real-time ultrasound is a valid and reliable way to assess pelvic floor muscle function. So when we look, and I want to show you this picture here so we can see, you have the bladder here, and up here is your abdominal muscles. So we're looking down at the bladder, and over here you have pelvic floor muscles and pelvic floor muscles. And that's what we can see sometimes on the real-time ultrasound. And then we teach people how to contract, and you'll see the bladder being lifted up. It's really kind of cool. And so there you can see it together. So a question is people say, is preoperative pelvic floor muscle training effective? There is some research out there. A lot of times it looks at most post-prostatectomy, but in this example here, they had an intervention group that had them become continent in 3.5 months. And then the control group was less than 50% was continent by 6 months. So once again, just showing it is effective to work pelvic floor muscles. And there needs to be more research done, but preoperatively is important too. So for every person, you should have, whether you have prostate cancer or not, doing some type of home exercise program. And of course, it's going to rely on personal responsibility, which is usually the hardest thing. For post-prostatectomy patients, we want to teach you toilet and leakage strategies. We want to look at an exercise routine both for your pelvic floor, for your abdominal muscles, and just cardiovascular, because cardiovascular exercise, 30 minutes on most days of the week, if not all, is very, very important. Stress relief. And we also talk about posture and different body mechanics. Sometimes when you're laying flat in bed and you sit straight up, that's going to put more stress on your abdominal muscles that have had surgery, and that can cause more leakage opposed to rolling to your side, dropping your legs off the bed, and pushing yourself up. So there's simple ways, too, to help decrease leakage as well. So is it about time for a little break right now? And welcome back after the break, everyone. We're going to get into talking about muscle isolation and activation. I'm going to ask that we continue to look up here. So when we look at muscle isolation and activation, it's really important that you know what you're doing from the pelvic floor. So there's a lot of different cues that I can give you to try and teach you how to activate your pelvic floor muscles. Typically, the first one is called tightening around the anus, and that is commonly used in research, which just recently they've had some research out from Paul Hodges over in Australia that showed that wasn't the most effective cue. But just like every person is different, I like to have a lot of different cues so we can find the right cue for each individual. Sometimes I'll instruct to try to pretend you're stopping the flow of urine. You can try to prevent from passing gas. Also, you can pretend you're a turtle and you want to pull the turtle's head into the shell. It sounds silly, but it's a very effective, and people think like that's a good visual with that. Another thing to do is you can say shorten the penis. Try to shorten the penis. And there's others we've used, and we try to find what's effective for each person. So there's also research has shown, and this is from Stadford, Ashton Miller, Constantine Hodges back in 2013, there's two different dominant muscle activation patterns found in men with pelvic floor muscle activation. There is a striated urethral sphincter dominant, where it compresses, and there's also the puborectalis dominant, which pulls up towards the pubic bone. So that's what they found through research, and this is one of the first studies that was devoted directly just to looking at the male pelvic floor. So we're going to play a game right now, everyone. I want everybody to sit up straight and tall, okay? So, and you're going to listen to my instructions. We don't have to look at anything. You can close your eyes if you want. Okay, so we're going to do 3 examples, and I want you to feel which feels the most for you. So, first one, I want everybody to try and tighten around your anus. So try to tighten around your anus and relax. Okay, we're going to do that again. Feel what your body is doing. Try to tighten around your anus and relax. Okay, next, I want everybody to try to pretend to stop the flow of urine. So imagine if you were urinating, we need to try to stop the flow of urine. So let's go ahead, try and stop the flow of urine and hold it. 1, 2, 3, relax it down. Again, we're going to try and pretend to stop the flow of urine. So stop that flow of urine and hold it. 1, 2, 3, relax. Now, last but not least, we're all going to pretend to be turtles. Or you can shorten the penis if you're feeling weird about being a turtle. Okay? So, so think about that your pelvis is this turtle, and you're going to pull the turtle head into the shell to protect it. So pull the turtle head into the shell and hold it. 1, 2, 3, relax. Now also, I never told people to hold their breath, and I totally see people in the audience here who are holding their breath, and that tells me you don't really know what you're doing, okay? So once again, we're going to pretend to be that turtle, pull the turtle head into the shell and hold it. 1, 2, 3, relax. Now, show of hands, how many people thought tighten around the anus was the best for them? Did anybody? Okay, got a couple people out there. Next, how many people tried to pretend to stop the flow of urine? How many people thought that was good? Okay, good. And last but not least, how many people like to be a turtle? So it's really great, as I see in this room, a couple people thought number 1 was best for them, some people thought number 2 was best for them, and some people thought number 3 was best for them. So it's important to have different ways to teach people how to do things, because not everything makes sense for all people. We're going to take some questions at the end. Is that okay? So once again, if we look here at some of the research done, shorten the penis and elevate the bladder, tighten around the anus. One showed that there was more greater anal sphincter activity. Another one showed that there was an increase in abdominal pressure, and another one showed that there was a dorsal displacement. So it's just showing that there's different cues cause people to do things slightly different, but it's effective for people. So there's different strategies, and the striated urethral sphincter responds best to the cue, shorten the penis. So does the patient's past medical history warrant another cue? If one thing isn't working, of course, let's figure out what works for each individual. That's like why I like to give a couple of options like we did. We tried 3 different ones. Now, if none of those work for you, come and talk to me after. Okay? There's a lot more to learn. When we look at the research, you know, teaching people to use their pelvic floor muscles effectively before surgery can give rise to much less incontinence. There needs to be more research in that area, but we have identified that pelvic floor muscle strengthening is the #1 treatment choice and should be the first line approach. And also, just like if you brush your teeth every day, which I hope you all do, pelvic floor muscle strengthening is something you should do every day. And I'll recommend between 30 to 60 muscle isolations per day. People think, oh my gosh, that's going to take so long. It takes less than 10 minutes usually. So, and you can always mix them into your day somehow. But there are also, we want to identify different patterns and different cues for both men and women. And for a long time, all the cues that we were using for women, we just assumed that men would respond to, but research has found that there are better cues for men. So should we train other muscles besides the pelvic floor? Of course, there's over 45 different muscles that attach in and around the pelvis. And so that's why it's important to see what else needs to be strengthened and support that whole pelvic area. So what if it's not working? For some of you who are saying, well, I am doing it. First, the question is, you got to have a little patience and you have to have realistic expectations. Okay? So just because you've done exercises for 1 week doesn't mean you're going to be perfect. Okay? A lot of times we look at doing exercises, they say it's 6 to 8 months for muscles to actually get strong, or I'm sorry, in 6 to 8 weeks you should see a change in strength. 6 to 8 weeks, a change in strength. However, post-prostatectomy, there's also healing going on. There can be some nerve damage. There can be nerve bruising, nerve irritation. All those things need to work. So you have to have realistic expectations. A lot of times we're talking 3 to 6 months easily. And there's some research out there that it says it can take up to 2 full years to fully heal post-prostatectomy as well. And it's important for compliance. That means you do, like I said, we want to treat your bladder like it's a 2-year-old. When I taught my children to say please and thank you, I did it every day, every time. In compliance, if we're doing exercises for the pelvic floor muscles and trying to get them stronger, we do them every day, just like we brush our teeth. There's different cues that you can practice, and then you can also work sometimes if these muscles just aren't listening at all and they speak a different language, then we can work with other muscles to try to get those pelvic floor muscles working too. And also, if you're just really frustrated and things aren't working, talk to your doctor or talk to a physical therapist. We're here to help you. So let's do some exercises, okay? So these are some basic exercises that I usually start with for patients. And so we just talked about the pelvic floor muscles, okay? So we can also think about, so I'm going to tell you, we just did some cues, and I want you, we're going to practice your cue of choice. And I'm going to count to 10. And when you feel the muscles start dropping or you feel you can't feel it anymore, that's when I want you to stop and remember what number I've said, okay? So for me, I like the turtle. So I'm going to say to everybody right now as we sit up with good posture, I love it. As I say that, over 75% change their position. So go ahead, and I want you to, shorten your penis or pull the turtle's head in, and we're going to count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Relax. So you don't have to tell me your number, but if you felt your number drop down at 3 seconds, then that's a good cue for your exercise program. So squeeze up, count 1, 2, 3, relax it down. Make sure you're breathing, okay? Now, how do we know if we're doing these correctly? Well, for men, after you get out of the shower and you're in the bathroom, as you squeeze, you should see the penis slightly move or the scrotum slightly move up. And that's one way to know you're doing it correctly. You can try, when you're urinating, to stop the flow of urine, but I do not want you doing that every time. That you just try once or twice to see if you're doing it correctly. If you have no clue what you're doing, talk to your doctor and ask to come to physical therapy. A lot of times men will come in and say, well, I've been doing Kegels for a year and I still leak. And when they come in and I check what they're doing, they've been bearing down or pushing down and out the whole time, so it actually makes them worse. So if you really don't know what you're doing, ask your doctor or come to physical therapy so that you can know correctly, okay? Because if you're going to put the effort in, we want to make sure we're doing it correctly. Another thing I like to say is it's really important. We talked about our body being a house, and when you think about the damage or the trauma your body has gone through, especially from the abdominal area, there's been some type of surgery going on. The transverse abdominis muscle is that big core muscle that you hear so much about that's really important. But how do we activate the core muscle? I'm actually going to move over to the chair here. So a very simple way to activate your transverse abdominis muscle is just sit up with good posture and push your heels in the floor. And relax. And you push the whole feet into the floor, not just the heels. And as you do that, you should feel a little activation in your tummy. That is one way to activate the transverse abdominis muscle. Now, we all, during life, sometimes we may gain weight, we may lose weight, we feel bloated, whatever. So another cue I give people is we're gonna put on a pair of pants, and they're a little snug. So as we zip up the zipper, and really I tell people, take your hand and pretend you're zipping up a zipper down here. You're gonna pull those lower abdominal muscles out of the way. Okay, and that's really the only muscle that should be using. So we zip up the zipper and hold it for 1, 2, 3, 4, 5, relax. Okay, another cue sometimes to activate those abdominal muscles is pretend like you're tightening a belt. For some reason, as we pretend to tighten a belt, it makes us pull our tummy in too. Now, when we activate our abdominal muscles, we have 3 layers of abdominal muscles. The first layer is the rectus abdominis muscle. Those are your 6-pack muscles, which I know we all have 6-packs here today, so we don't even need to look at them. The next layer, you have your internal and external obliques, and those run on diagonals. And that deepest layer is the transverse abdominis muscle that runs from your bottom hip bone to your bottom hip bone. So that's why we really want to focus on that deepest muscle, because it wants to go to sleep. It wants to pretend it's not there, but it's a very powerful muscle of stability that we all need. So these are some simple cues that you can try at home. Now, obviously, I don't know each and everyone's personal situation, so if you do something and it's causing problems or it's causing you pain or something like that, don't do it, and talk to your doctor and see if you can come to a regimen physical therapy. And I'm also going to tell you how you can find a physical therapist like me, hopefully close to your house. Otherwise, you can email me and I'll happily help you guys find some people. So there's always really good stretches too, and I have to tell you, I have a bias with men. I believe all men were born with hamstrings that are tight, and it's not supposed to be that way. So our hamstrings muscles, as I said, are the muscles that are on the back of your thigh here. A very simple hamstring muscle is to put your foot up on a chair, keeping the legs straight. So you're going to pretend there's a chair under my foot, and then I just lean forward. And as you lean forward, you'll feel some tightness behind your knee, and that's getting your hamstring muscle. Now, research has shown that when we are stretching our muscles, whatever muscle we are stretching, we want to hold it for 30 to 60 seconds, and that actually allows it to lengthen. So if you don't hold it, people say, oh, I'm doing stretching every day, I hold it 10 seconds. That's not allowing those muscle fibers to actually lengthen. Okay, so hamstring muscles are very easy. Another stretch that you can do that I personally love is if we cross our legs like this. So if you guys want to scoot back for a second. And those of you who can cross your legs, and if you can't, you can watch and take notes. So all you do is cross your leg and you gently lean forward. And as you lean forward, you should feel back by your buttocks and underneath your thigh some tightness there. We're going to sit and hold it for 30 seconds, everyone. Make sure you're breathing. I didn't tell anybody to hold their breath. And if you have problems where you have a tendency to hold your breath, that's when I tell people to count out loud, because then at least I know there's a little bit of an air exchange going on. And I am watching the clock, so some of those who are like, is she done yet? We still have 6 seconds to hold into this stretch. And this is going to help some of the posterior muscles by your butt and some muscles into underneath on the thigh too for stretching. And now we can relax, bring that leg down. And we're going to go to the other leg. And this is wonderful. When I'm in meetings at work, I do this all the time. I still pay attention, but I still can do this. So go ahead, change legs, lean forward, and hold it. Make sure we're breathing. And I'm watching the clock for our 30 seconds. When I do stretching, I usually recommend we do 3 times on each side, if this feels good. And now you can control how much you stretch. Some people can lean even more, and some people go, oh, that's too much, Heather. Then I say, back up. Find what's comfortable for you. Stretching will be a little uncomfortable, but it shouldn't cause straight out pain. Okay? I realize some people may have bad knees and this doesn't feel good to them, then don't do this. Okay? And we got a couple more seconds and we are done, and relax. So normally I would go back 3 times on each side, but due to time today and want to make sure I have plenty of time to answer questions, we're going to keep moving on. Normally, we come down to just a basic beginning incontinence program. We just did the sitting piriformis stretch. Then I like to do adductor squeezes. And so what is that? So I would take a ball, a small ball, or a rolled up towel, or a roll of toilet paper, or a roll of towel paper, and I take that and I roll it up and I put it right in between my knees. Now normally my ball would be a little bigger, but I would take and I would just squeeze my knees together and I'd count to 5. 1, 2, 3, 4, 5, and relax. Again, 1, 2, 3, 4, 5, and relax. This activates your adductor muscles. Your adductor muscles attached to the base of your pelvis. So every time we do this, it helps to pull on the pelvis to make sure your pelvis is in alignment as well. This is a pelvic floor muscle facilitator. This is a great exercise that says good morning to the pelvic floors and tells them that we need to get them working without picking on them right away. Next, I also do a resisted abduction when you can get a little TheraBand, or there's a variety of different cords, and I'll put them around my thighs, my lower thighs close to my knees, just like this. And it's very simple. And then I sit with good posture once again. I have this recurring theme of good posture, if anybody's picked up on that. And we go and we open up and I hold it and I count 1, 2, 3, 4, 5, and I bring it in. And I open it up again, 1, 2, 3, 4, 5. Usually when I do these, now for stretching, we hold it longer and we usually do 3. When I do a strengthening exercise, I do sets of 10 and I want to work up to 3 sets of 10 once or twice a day. Because after we go through any type of surgery, rehab is our job, right? To get us healthy and back in. And the last exercise there on the screen is talking about the abdominal activation, which we talked about with using the zip up the zipper or tightening our belts, okay? So those are just some basic things. Once again, I don't know everybody's personal history or whatever, so if it causes some problems, stop and ask your doctor. Okay, continuing on. What else might you need? Research has shown that for anybody dealing with any chronic problems or recovery and having difficulties, the best approach is a multidisciplinary approach. Multidisciplinary, pull in different people from the medical field. When we look at a lot of my patients, I make sure there's stress management, there's relaxation techniques. We go other incontinence tools and education. Psychological support and counseling is very, very important. Nutritional referrals, sometimes social works, case managing, and I'll also many times refer back to your doctor. There's a lot of good support groups out there. When you're going through it, it makes life a little easier when you know somebody's been through it and they can give you some tips to help make it easier for you. So don't be afraid to ask for help, and through us too, there's some great resources that are provided for you as well. So what does this all mean? Some take-home messages is, number one, that pelvic floor muscle strengthening is recommended as a first-line treatment, but sometimes you have to teach the pelvic floor muscle to relax before you strengthen it. Usually in post-prostatectomy, it's typically more of just a strengthening issue. We need to individualize a program for each person or each patient to include more than just pelvic floor. Sometimes we got to work on those abdominal muscles. Sometimes we have to stretch the hamstrings. That's why we want to look at the individual. But for every person here, you have to take your own self-responsibility. I can't strengthen your pelvic floor for you. I can't make your hamstrings longer. It's about you waking up every morning and choosing to do it, even when it's really hard and you're going through a lot. So when you think about if you want to come to physical therapy, usually you need a prescription depending on the state that you live in. In Illinois, we do have some open access, but usually still for insurance you need a prescription to come in. So your primary doctor, your oncologist, your urologist, sometimes there's colorectals, nurses. So if you're having problems and you want some more individual assistance, ask your doctor or medical provider for some help. Also, take-home messages with incontinence. There's a lot of good treatments out there. You talk with your doctor to find what's right for you. Once again, pelvic floor muscle strengthening is really important. It's not going to hurt you, okay? And it's free. It just takes a little bit of your time. Secondly, usually you need an individualized program to figure out not what's right for you may be different for somebody else. So it's important to ask for your doctor. So it's also important to treat the whole person, from mind, body, and spirit. And so that's why we say a multidisciplinary approach. Sometimes we need support groups, we need counseling, we need nutrition, whatever you may need. We have to treat that whole person, not just their pelvic floor. And resolution and muscle dysfunction is essential for improving quality of life in men with incontinence and erectile dysfunction. So here's a couple ways to find a pelvic floor physical therapist. Through the American Physical Therapy Association, you can go to www.apta.org, find a therapist. There's also through Herman and Wallace, through the section of Women's Health or the Academy of Pelvic Health, you can find a therapist there. You can come and ask me, and I'm happy to give you guys my email too. There's some references, and if you have any questions, we'll open up for questions right now.
Can you get benefits after radiation?
Yes. And if you just want me to elaborate on that a little bit, once again, radiation, is going into the area, and it does cause some damage to the muscle tissue there, but there's still other muscles in the area, and when we work on pelvic floor strengthening, that's going to bring blood flow to the area to help with heal some of the tissues that they can. So it's definitely worth a try. I've seen great results from some patients.
This may have an obvious answer, but in one of your slides you mentioned that there are like 45 or more muscles that connect to the pelvis, and prior to let's say prostatectomy and post, how important is walking? If you're able to jogging, and those kinds of exercises as well. I mean, is that just put frosting on the cake? Is it matter a lot or not so much?
Well, first of all, I believe what you're asking is more about cardiovascular exercise, and cardiovascular exercise is very important. We can look at the NIH, the National Institute of Health, Mayo Clinic, Cleveland Clinic. You know, there's so many people that say we need cardiovascular exercise on most days of the week, if not all, and that's usually 30 minutes. Okay, they want to say 30 minutes. Some people say, well, I don't have time to do 30 minutes. Well, then do 15 in the morning and 15 at night. That still counts. And cardiovascular exercises is going to help keep us healthy. It helps decrease stress. When we exercise, we get our good drug, which is our endorphins. It helps for heart health. It helps decrease the risk of stroke and heart attack. There's so many benefits of it. The more fit you are going into any disease process, the better outcomes you're going to have on the other side most of the time. So yes, it's really important. And even if we don't have prostate cancer, keeping ourselves fit and healthy, I think about where I'm at 29, and I want to see where I'll be at 39 and 49 and 59 to keep myself healthy so that I can do the things I want. And part of that is cardiovascular exercise and a variety, seeing your doctor every year for your health checks so that if you are unfortunately going to be diagnosed with something, we catch it early. Other questions? Oh, one question online.
How important is the prostatic sphincter for being continent?
The what sphincter?
Sorry, how important is the prostatic sphincter for being continent?
Well, when we talked about the sphincter, you know, you have your external anal sphincter. And it depends. I mean, it's one of the things that help with closure. So, you know, that's going to be very important. And sometimes in prostatectomies, some of that may need to be removed. And then we have to find, and that's where the pelvic floor muscles, we're going to need them to do even more of a job to work on those 4 things for the sphincteric control, for closure. Yes. Do we need the mic?
Yeah, Daniel's got it.
Oh, I'm sorry.
Yes, it's 7 to 9 sets of 10 of Kegels excessive on a daily basis.
7 to 9 sets. Usually, I recommend saying to do 3 sets of 10 twice a day, and you can kind of build up for it. The question is, how many seconds can you hold? So if you're able to do, you know, do I want you doing 7 to 10 all at once? No. And for some people, right post-prostatectomy, when we're able to start activating that pelvic floor muscles, I'll tell them to do 10 every hour just to get those muscles. So we don't want to overload, but you also want to figure out, you know, so if you space it over the day, that would be fine.
And what about, do you recommend Vikram yoga to help support flexibility and strengthening of core?
I recommend any type of exercise that will motivate you. I think there's lots of good options, from different types of yoga to different types of Pilates to kickboxing. Now, with that being said, if we have a lot of urinary leakage post-surgery or anytime if we're doing higher level activities like kickboxing, we may have more stress urinary incontinence. So you want to be practical at what you're doing and start out. And if you're not doing any exercise, start out with a walking program. Or you can ask your doctor for what is right for you.
How does riding your bike affect the muscles, the pelvic muscles? Because putting pressure in that area could actually make it worse, but you're exercising.
Yes, and thank you. That's an excellent question. It opens a bit of a can of worms here because there are some patients, and I mentioned early, that have prostatitis. If they have prostatitis, sometimes sitting on that bike seat can cause some pain issues. But if you don't have any problems with that, you know, once again, cardiovascular exercise is really good, but also it's kind of like running a marathon. This body will never run a marathon, but if I was going to start training, I'm not going to go and run 26.2 miles. I would start by starting out slow. So if you're starting an exercise regimen, you want to start out slow. So if you're going to start out biking, you would start out not with 26 miles. You would start out for, you know, a little bit. So, but if you find some irritation to the pelvic floor, that's something you can talk to your doctor or a physical therapist about and find other exercises that are appropriate for you.
One more question?
I have a question about walking. I was reading something about bone density, and it said weight-bearing exercise like walking is very good for building up bone density. But you were saying it was cardiovascular. Is weight-bearing lifting weights, or is it also lifting the body with walking?
You're exactly right. That weight-bearing exercise, walking, is one of the best weight-bearing exercises. And also, back to something I said earlier, having good posture so that when we sit up straight and we sit through all our bones, we sit through the bones in the pelvis. It kind of goes back to if we don't use it, we lose it. And that kind of goes along the lines with bone density. So weight-bearing exercising with walking is perfect. That's excellent. And when you look at different exercises, you get lots of, depending on the type of exercise, we get lots of different benefits. With walking, you can get cardiovascular benefits. You get the benefits for bone density and weight bearing. But also when we walk, are we walking along window shopping? No. We want to get it so that we're getting our heart rate up a little bit, like that. So it's a great exercise, yes.
Okay, thank you so much, Dr. Mookie Cordova.
It's been a pleasure to be here today. I'll stay around for additional. Thank you and good luck to you all. Okay.